Good evening, everyone. Am I audible, visible? Am I? Could you see my slides? Okay, done. Could you see my slides? Okay, then. Right. Shall we start, my dear friends? Done. Yes. Today, our topic will be on pediatrics, and we are going to cover certain important topics that will be asked in our entrance examination. We all know that the one thing that you need to know is regarding vaccination. At least one question from vaccination will be asked. Going to our topic, let us start. Our first question will be on this. The following vaccine is given at 5 years as per National Immunization Schedule. I repeat, the following vaccine is given at 5 years as per National Immunization Schedule. Is it DPT, DT, TD or DTAP? Waiting for your answers. Is it DPT, TT, TD or DTAP? What is the answer? The following vaccination is given at 5 years as per National Immunization Schedule. Answer is it A, B, C, D. I have been seeing C, C, D, C. So many answers. Is it correct? Everyone are opting for C. Everyone are opting for C. The answer is correct or wrong? DPT, capital D, small p, small t. Sunil Sharma, C. Chifina, TD. Yes, almost all of you are not on your right track. The answer is yes. Vikas Sharma is good. Lakshmi Krishnan is good. They are good. They have opted for answer A. Lakshmi Krishnan, it should not be small d, small p, small t. It should be capital D, capital P, capital T, because it is the antigenicity. That is the dose of the vaccine that they have been maintaining. Answer is A. First one. The answer is A. It is not C. It is not D. The answer is A. DPT, when it was given? DPT is given at 6 weeks. It is given at 10 weeks. It is given at 14 weeks. This is called primary series. This is called primary series. Whereas at 16th month and at 5 years, they are called booster doses. They are called booster doses. 6 weeks, 10 weeks, 14 weeks is called as primary series, whereas at 16th month and 5th year are called booster doses. And at 10th year, you give capital T, small d. Tetanus remains the same, whereas the dosage of diphtheria is reduced. Why is it so? Because we have been seeing numerous cases of diphtheria in the year 2018. There is a big diphtheria outbreak in the year 2018, as a result of which your TT at 10 years has been replaced by TD. And the MCQ is your DPT is given at 6 weeks, 10 weeks, 14th week, primary series, followed by booster at 16th month and 5 years. And it is followed by TD, capital T, small d at 10 years. So the answer is DPT at 5 years. Right. Let us see the national immunization policy as a whole right now. Let me wait tell me what is the vaccination you give at birth? What is the, is it okay for you, my dear friends? My dear friends, is it okay? The answer is 6 weeks, 10 weeks, 14 weeks, 16th month and 5 years, followed by TD at 10 years. Okay. Okay, my dear brothers and sisters. Now, let us go to the national immunization schedule. I am not going to talk about the vaccines which are available in private setup. Let us concentrate on only vaccination that are given at national immunization policy. What is the vaccine that is given at birth? Neelam Bhatia, yes, it is good. It is BCG, hepatitis B, as well as OPV 0. Then yes, all are correct, I agree, except Darshu. What are all the vaccines that are given at 6 weeks, 10 weeks and 14 weeks? What are all the vaccines that is given at 6 weeks, 10 weeks and 14 weeks? Remember, my dear friends, at 6 weeks and 14 weeks, the vaccine given are one and the same. I repeat, the vaccine given at 6 weeks and 14 weeks are one and the same. What are all the vaccines that are given at 6 weeks and 14 weeks? Let us see. So, you give OPV. Let me change the color. At 6 weeks, OPV, oral. Second one is rotavirus, oral. Third one is pentavalent, IM. What else? OPV, rotavirus, pentavalent. What else you give at 6 weeks and 14 weeks? You give PCV. As well as you give one more vaccine. What is this vaccine? IPV. That IPV is intradermal. That IPV is fractionated IPV. That IPV is intradermal. So OPV1, Rota1, pentavalent 1, PCV1 and intradermal IPV at 6 weeks. The same vaccines are given at 14 weeks. What are all they again? So it is OPV 3 and then Rota 3 and then you have your pentavalent, you have PCV second dose and then you have IPV, fractionated IPV second dose. IPV is intradermal. Sweta, you can post your questions, no issues. Intradermal. Then, what is the vaccine that is given at 10 weeks? It is very, very simple. You give OPV 2. You give OPV 2. You give Rota 2. You give pentavalent 2. You give pentavalent vaccine 2. But you are not going to give PCV vaccine and IPV vaccine. The answer is this. You are not giving PCV vaccine and IPV vaccine. Except that all are one and the same. OPV, Rota, pentavalent, PCV, IPV, all are given at 6 weeks and 14 weeks, whereas your PCV and IPV were not given at 10 weeks. This is the MCQ. Very good. MCQ. What does pentavalent contains? The answer is very easy. What does pentavalent contain? Pentavalent contain diphtheria, pertussis, tetanus, your hepatitis B, as well as your Haemophilus influenza type B, your HIB. This is called pentavalent vaccine. vaccine. What is the vaccine that is given at ninth month? What is the vaccine that is given at ninth month, my dear friends? What is the vaccine that is given at ninth month? The vaccine given at ninth month, anyone? What is the vaccine given at ninth month? Again, you will give OPV. What else? Is it measles, measles rubella, or measles mumps rubella? Is it measles, measles rubella, healthy pill, JE, PCV, IPV? Who is that healthy pill? I don't know. But yes, you are giving measles rubella dose 1. You are giving Japanese encephalitis dose 1. And so far in the past 3 years, we have been giving PCV booster. PCV booster. But government in the past 1 year has introduced another booster dose of dash. Who is that? Neelam Bhatia. Very good. Government has introduced fractionated IPV booster. Government has introduced fractionated IPV booster. Very good. It is measles rubella 1, Japanese encephalitis 1, PCV booster as well as IPV booster. Intradermal IPV booster. Vikash Sharma, very good. Neelam Bhatia, very good. They are the recent introductions into our national immunization schedule. Right. What about the vaccines at 16 to 24 months? What about the, very good, very good. All are correct. All are correct. Very good. What about the vaccines that are given at let us see, given at 16 to 24 months? Yes, you are all correct. Again, OPV you have been giving. You are giving measles, rubella second dose. You are giving JE second dose. You are giving measles, rubella second dose. You are giving JE second dose. Yes, you are giving DPT booster. You are giving DPT booster. Measles, rubella 2, JE2, DPT booster as well as OPV. And finally, yes, we will be giving you all PDF. Do not worry, my dear brothers and sisters. Don't worry. What about 5 to 6 years as the MCQ? Yes, vitamin A. We are speaking about a vaccine. Yes, thus vitamin A is given. We will be discussing it along with our nutrition topic. Arun, sir, from 9 months till 5 years, vitamin, yes, vitamin A supplementation is given. I am talking about vaccination. By about 9th month, you give vitamin A. By about 16th to 16th month, vitamin A. 24th month, vitamin A. Until 5 years, every 6 months, vitamin A is given. I am talking about vaccine, my dear boys and girls. At 5 years, it is, I repeatedly I am telling, Vicky, please write it as capital D, capital P, capital T, because it is the same antigenic dose that we are maintaining, my dear brother. It is capital D, capital P, capital T. So it is DPT. At 10 years, what is the vaccine, my dear brothers and sisters? It is capital T and small d. It is capital T and small d. That's why the dosage of diphtheria remains, the dosage of tetanus remains the same, but the dosage of diphtheria is reduced. The antigenicity is reduced. Okay. At 10 years, it is TD. Okay. Okay. What is Mission Indradhanush? What are all the vaccines that are covered in Mission Indradhanush? Anyone? I am awaiting my my kid's answer. What is Mission Indradhanush? Mission Indradhanush. What are all the vaccines covered by Mission Indradhanush? Yes, my dear boys and girls. What are all the vaccines covered? How many vaccines covered? First question, how many vaccines? Vaccines, again, what is the target? How many vaccines? Second question is, what is the target they have set? What is the target? How many vaccines? How many vaccines? How many vaccines? 7, now 12. Let us speak about those 7 vaccines. So 7, and they are aiming for, yes, 12. What are all those vaccines? These are all the vaccines that we have seen so far. What is the target coverage, my dear? What is the target coverage? The target coverage is more than 90%. The target coverage is more than 90%. Okay, the target coverage is more than 90%. This is called Mission Indradhanush. So far, it is 7 vaccines throughout the country, but they are aiming to increase to 12. So what are all the vaccines that are aiming to cover throughout the India as of now? It is OPV, it is BCG, it is diphtheria, it is tetanus, you have your pertussis, and then hepatitis B, OPV, BCG. What else you have? Measles, and then you have your measles. They are targeting for this at present. They are targeting for this at present throughout the country, and it is going to be 12 soon. Can anyone tell me what is the valency? What are all the number of strains that is present in our PCV vaccine? Because very few countries have introduced PCV vaccine. What is called PCV vaccine? PCV vaccine is called pneumococcal conjugate vaccine. It is called pneumococcal conjugate vaccine. It is called PCV10, and it is called as Nemosil, That is the vaccine that they are giving right now. Now the next question is, where you will give all these vaccines? Yes, to start with, what are all the places you give all these vaccines? It is very, very easy. You need to start from the left hand, and then you need to go to the right hand. This is how you need to put your vaccination. So what are all the vaccines that you are giving at your left hand? To start with, OPV, the answer obviously goes without saying, oral route. Rotavirus, yes, oral route. What are all the vaccines, other vaccine? BCG, where you need to give BCG vaccine. To start with the BCG vaccine, where you will give? Answer. The BCG vaccine will be given intradermal. Yes, at the level of the insertion of the deltoid. BCG vaccine is given at the level of the insertion of the deltoid intradermally. What will happen if you give above the level of the insertion of the deltoid, or you will give in the subcutaneous route? Can anyone tell me? Okay. Yes, it is given at free of cost in almost all states, my dear. Okay. Right. So, what are all the vaccines? And where they are giving? Look here. At 6 weeks and 14 weeks. At 6 weeks and 14 weeks, OPV, oral route, rotavirus, oral route. Whereas your BCG is given where? Your BCG is given at left intradermal area. Your BCG vaccine is given at left intradermal area. Your pentavalent, so here you will give your BCG left intradermal. And then your pentavalent vaccine is given at left anterolateral thigh. Intramuscular anterolateral thigh, your pentavalent vaccine. And your PCV vaccine is given at right intramuscular thigh. Your PCV vaccine is given at right anterolateral thigh. Right. your PCV vaccine. And finally, your intradermal IPV is given on the right hand. Your intradermal IPV is given on the right hand. So it is very, very clear. Oral, 2 vaccines. Your OPV and Rota. Left side intradermal, it is BCG. Right side intradermal, it is IPV. Left intramuscular, it is your pentavalent painful vaccine. And your right intramuscular anterolateral thigh, you will give your pneumococcal or pneumococcal conjugate vaccine. This is given at 6 weeks and 14 weeks. Why IPV is given on the right rather on the left? Because you are giving BCG vaccine. If you give fractionated IPV vaccine on the left side, definitely it will lead to confusion, because BCG is going to produce a scar that can last for about 6 to 12 weeks. 6 to 12 weeks. And then, what are all the vaccines that you are given at 9th month? You have JE vaccine, you have PCV vaccine, you have intradermal IPV. Since you are not giving IPV vaccine, since you are not giving BCG, your left arm can be utilized. So, your left arm intradermal for IPV. Left arm. So, left arm fractionated IPV, intradermal left arm. Intramuscular or subcutaneous, your JE vaccine. JE vaccine subcutaneous, it is a live vaccine. All killed vaccine and conjugate vaccines are given intramuscularly. All live vaccines are given subcutaneous route. JE vaccine, subcutaneous. Right side, it is very, very simple. Your PCV booster. Your PCV booster. And finally on the right arm, subcutaneous measles rubella vaccine. So, subcutaneous right arm, your measles rubella vaccine. Okay, measles rubella vaccine. No, it is not JE. Someone has written left arm subcutaneous JE. No, it is left thigh anterolateral intramuscular JE vaccine. Left intradermal IPV, right subcutaneous MMR and right intramuscular PCV booster. Again, they will be asking you what are all the routes by which you will give your vaccine. I repeat, all live vaccines are given through subcutaneous route. All killed vaccines, toxoids or conjugate vaccine are given in the intramuscular route. Again, they can ask you, what is the distance that you need to give? It is 1 inch depth in the anterolateral thigh. I repeat, my dear friends, it is 1 inch depth anterolateral thigh. Okay? So, we have completed 2 questions. Then, let me see the following. Is it okay, my dear boys and girls? Let us go to the second question. Numerous questions that can be asked in this discussion. Now, the following vaccine is kept at the middle compartment of the refrigerator. I will be waiting for my boys and girls to answer. The following vaccine is given at the middle compartment of the refrigerator. Where will you keep your BCG? Where will you keep your OPV, BCG, MMR and then DPT? I am waiting for my boys and girls to answer. My brothers and sisters to answer. Answer pa? Yes. The following vaccine is kept at the middle compartment of the refrigerator. Middle compartment. Middle compartment. The question is middle compartment of the refrigerator. Answer is A, BCG. Someone has written BCG. BCG. Okay, B, middle compartment. Okay. Let me say, the most heat sensitive vaccine and light sensitive vaccine is what? OPV. So, OPV is kept in the freezer compartment. OPV is kept at the freezer compartment. 1. Second, then after the freezer compartment, you have your next to first compartment, middle compartment, lower compartment. OPV is kept in freezer compartment. Then First compartment, middle compartment, and then lower compartment. Here the temperature is 2 to 8 degrees Celsius. First compartment I mean next to the BCG, next to the freezer compartment. BCG is kept at the first compartment, closer to the refrigerator, closer to the freezer compartment. Your MMR is kept at the first compartment, that is next to the freezer compartment. And finally, all tea containing vaccines. What are all the tea containing vaccines? Your TT we are not using right now. Your TD that we are using at 10 years. Your DPT, okay, your typhoid which is not given in the national immunization schedule. What else you have? You have, apart from that, what else you have? You have your hepatitis, okay, A. What else you have? You have your varicella and then hepatitis B. Hepatitis B. Okay, and then or else I can simply say all tea containing vaccines are in the middle compartment. Lower compartment. Okay, lower compartment. You can keep your varicella again in the lower compartment, or hepatitis B again in the lower compartment. Varicella and hepatitis B can be kept in the middle or lower compartment. And finally, door. No vaccine should be kept in the door. No vaccine should be kept in the door. So what is the answer, my dear boys and girls? What is the answer, my dear boys and girls? The answer is Darshu, the answer is Vikash, the answer is DPT. Answer is DP. In order to have a pictorial memory, okay, see this. What is the vaccine that is kept in the freezer compartment? It is B, C, G. In the main compartment, top rack, middle rack, lower rack. Top rack, I am sorry. You will keep your slip of tongue. You will keep your OPV. Top rank, you will keep your BCG and measles containing vaccine. Whether it is measles, rubella, measles, mumps, rubella. Okay, va? Measles, mumps, rubella. Right. Measles, mumps, rubella. Again, all tea containing vaccines. Let it be DPT, as I told you, TT, as I told you, TD, typhoid, all in the, as well as hepatitis A. Hepatitis A in the middle compartment. And finally, your varicella and hepatitis B are kept in the lower compartment. Yes, we will be giving you PDF ma, don't worry, just listen, my dear boys and girls. So in case of door, nothing is kept. In case of door, no vaccine should be kept. In case of door, no vaccine should be kept. Okay? So our next question is over. So the answer is D. Answer is D. What is this? Often asked question in AIMS I have been seeing. Catch-up vaccination. A 8-month-old, let us go to, okay. A 8-month-old child who has received 1 dose of OPV. 8-month-old child who has received 1 dose of OPV and DPT at 2 months of age. That is at 6 weeks. What will be your next immunization plan? What will be your next immunization plan? Tell me. Waiting for your answers, my dear boys and girls. What is your immunization plan? 8-month-old child who had received OPV DPT at 2 months, what will be your next immunization plan? Restart immunization as per age. measles BCG booster dose of DPT OPV, measles booster dose of DPT OPV, BCG second dose of DPT and OPV. Das has opted for D. Nisha, Vikram, everyone else have opted for almost all. Yuvaraj, all are opting for C. Can we go to the explanation, my dear boys and girls? Can we go to the explanation, ma? Let us go to the explanation. The first thing that you need to know is whenever any vaccine is missed out, it doesn't mean that you need to start the vaccination again. Point number 1. No need to start revaccination at any point of time. 1. Second point, catch up vaccination with respect to BCG. As per National Immunization Schedule, BCG can be given up to 1 year. BCG can be given up to 1 year. Okay. But as for Indian Academy of Pediatrics, BCG can be given up to 5 years. But for my boys and girls, I want to make it clear that BCG vaccination, as per immunization schedule, can be given up to 1 year. Point number 1. Second point is your capital D, capital P, capital T, DPT can be given up to 7 years. After 7 years, these are all the concept you need to know, my dear boys and girls. BCG can be given up to 1 year. Your capital D, capital P, capital T, diphtheria, pertussis, tetanus vaccine can be given up to 7 years. But after 7 years, pertussis will produce predominant local side effects such as pain and tenderness. As a result of which, your pertussis, whole cell pertussis, has to be replaced by acellular pertussis, that is called small a and small p. And remember, hepatitis B missed out schedule is 3 doses. Diphtheria, pertussis, tetanus missed out doses 3 doses. And last concept is after 7 years, only 1 dose of diphtheria is fine. With all these points in our hand, let us go to the answer. Let us go to the explanation. Less than how many times we need to ask the patient to come? At the first visit, 1 month after, 2 months after, 6 months after. Concept 1. BCG vaccination up to 1 year can be given. The child here is less than 7 years, less than 1 year. This is a 8-month-old child. So can I give back BCG vaccination, my dear boys and girls? The answer is right. Can I give BCG vaccination? The answer is yes. BCG vaccination can be given. Point number 1. It can be given up to 1 year. Here our child is 8 months old. Second point. Remember, my dear boys and girls, you all know the schedule of hepatitis B. Yes or no? Almost each and every one of you have undergone or have taken an hepatitis B vaccination. Each and everyone knows, whether it is you are a medical person or paramedical person, you know it is 0, 1, 6. So fill it very, very easy. So 0 at the first visit, hepatitis B. 1 next month, hepatitis B, and then after 6 months, hepatitis B. Is it clear, my dear boys and girls? Hepatitis B 016. In the same way, your diphtheria, pertussis, tetanus can also be given as like DPT vaccine, because you know that pentavalent vaccine contains one and the same. In the same way, the same principle holds good. Your DPT vaccine can be given at 016. Now the question arises, is it capital P or small p? Is it the antigen one and the same? It was explained a minute back. It is capital D, capital P, capital T at all years. Someone is asking, Aruna, why less than 7 years? Why less than 7 years? Because after 7 years, you are not supposed to give wholesale pertussis vaccine. You are not supposed to give high antigen laden capital DPT vaccine. That's why the 7 years is fixed. Okay. Now, as I told you, DPT at 0, 1 and 6. So, DPT, DPT and then DPT. Is it okay, my dear boys and girls? Hepatitis B at 016, DPT at 016 also you are include. Never forget OPV. Never forget OPV. If the child is less than 5 years. Less than 5 years. Now, let us, sir, you are not filling that 2 months table or column. Don't worry, let us make it easy, my dear boys and girls. Let us make it easy. After 7 years, are you going to give OPV? No. After 5 years, no need. Are you going to give BCG? No. Then what are all the things? Are you going to get hepatitis B? The answer is one and the same. Yes, hepatitis B. Hepatitis B. And then hepatitis B. Yes, cool. With regard to DPT, it was mentioned after 7 years you are not going to give. After 7 years you are not going to give wholesale pertussis. You need to give acellular pertussis. So how I can write? I can write small a, small p. I can write small a, small p. Okay. Point number 1. Second point is you are not going to give wholesale. So acellular pertussis, small a, small p. After 7 years, someone asked, Aruna, you asked, are you going to give diphtheria with a high antigen? No, you need to give only low antigen. So instead of capital D, it has automatically become small d. It has automatically become small d. So it is instead of capital D, I am writing small d. And finally, tetanus remains the same. Tetanus remains the same. So it is called Tdap. To mention, it is called as Tdap. T, capital T, small d, small a, small p. Tetanus remains the same. Capital D becomes small d. Antigenicity is reduced. Wholesale pertussis has become acellular pertussis. That's it. It was discussed only one dose of diphtheria is sufficient after 7 years. So, do I need to give one dose of not diphtheria, one dose of pertussis? I'm extremely sorry. One dose of pertussis is given after 7 years. No need for repeated pertussis. As a result of which, booster doses at 1 month and 6 months is remove your acellular pertussis. So, it becomes capital D, small t, capital D, small t. Again, Lakshmi Krishnan, you have written small t, small d, small a, small p. It is capital D. I repeat, one slip of tongue, only one dose of pertussis is essential after 7 years. I told it is diphtheria. Only one dose of pertussis is essential after. So, this is how you need to write. Finally, at 2 months after the first visit, what are all the vaccines? Very, very simple. What is the vaccine that is left out, my dear boys and girls, my dear brothers and sisters? Very good. Measles. In government setup, measles. In private setup, measles and typhoid. So, at 2nd month, we don't have much change with respect to less than 7 years or more than 7 years. So, the answer is measles and typhoid, whatever may be the age. I have witnessed so many times in INICET, they have included this catch-up vaccination schedule. That's why I took such a long time to describe this. Even a single answer will make so much of difference in your entrance examination. Okay, my dear boys and friends. So what should be the answer? Tell me. What should be the answer? An 8-month-old child. Don't look into the question. My children will answer right now. I 8-month-old. Do I need to give DPT? Yes or no? Do I need to give DPT? Yes. Do I need to give hepatitis B? Yes. Do I need to give BCG? The child is 8 months old. So what is the answer, my dear friends? What is the answer? Let us go back. Let us go back. It was told it is a 8-month old child. It is a 8-month old child. It was told no need for repeat or to restart the immunization. Restart the immunization. Very good, Ra. Very good. Very good. Healthy pill. Very good. Healthy answer. Less than 1 year BCG. No need to restart. So second dose of DPT. You can give OPV. But you can also include what, my dear friends? Hepatitis B. Hepatitis B. Why C is not correct answer, pa? Because measles you give at the second month. 0, 1, 2. Second month we are giving. So it is not the answer. BCG, measles, booster dose of, you are not going to give booster. Even the children has not completed primary series. Now again, measles doesn't come in the first visit at the catch-up vaccination schedule. And finally, restart immunization. Again, this is wrong. This is wrong. Hope my dear kids had understand the concept. I repeat, less than 1 year BCG can be given. 016 diphtheria, pertussis, tetanus and hepatitis B. Less than 7 years it is capital D, capital P, capital T. Whereas capital D, capital P, capital T. At 016, more than 7 years, remember only one dose of pertussis would do. Concept 1. Diphtheria has to be replaced by small d, and your wholesale pertussis has to be replaced by small wholesale as acellular pertussis. So it is Tdap at 0, Td at 1 month and TD at 6 months. At second month, what are all the vaccine? Measles and typhoid vaccine. Someone had asked, do we give measles after 5 years? Ansh Bansal, I am talking about pediatric age group. Okay. If you are asking, since Ansh Bansal has asked measles, mumps, rubella, let me tell you one more entrance MCQ. Let me tell you, thanks for reminding me of this entrance MCQ. The one vaccine that can be given at any age group is measles, mumps, rubella. The one vaccine that you can give at any age, whether you are 10 year, 20 year, 50 year, 40 year, 65 year, 75 year, the only vaccine that can be given at any age is measles, mumps, rubella. Tarankadas, if there is epidemic of measles that can be given after 5 months, usually measles rubella given at 9 to 12 months first dose and 16 to 24 months second dose. If there is an epidemic, it can be shifted to 6th month. The answer is yes. The one vaccine that can be given as a catch-up vaccine for any age group is measles, mumps, rubella vaccine. Right. So concept 3 over immunization. Okay, let me ask my dear friends, when you give, what is the vaccine? Let me add some more tidbit points for my children. Okay, you are my children. Let me ask some more tidbit points. Symptomatic HIV. Let me add some tidbit points. Symptomatic HIV. What is the vaccine that you are not supposed to give? Symptomatic HIV. What vaccines are contraindicated? What vaccines are contraindicated? Symptomatic HIV and asymptomatic HIV. What's asymptomatic HIV? What vaccines are contraindicated if they are, and provided CD4 count is more than 15%. CD4 count is more than 15%. I am waiting for my children to answer. Symptomatic HIV, what 2 vaccines are strictly contraindicated? Measles, mumps, rubella is a Live vaccine, Raja, Tarankadas, measles, mumps, rubella is a live vaccine. Can it be given to a symptomatic HIV? Only 2 vaccines cannot be given in symptomatic HIV patient. What are all they? One, as you told, live viral vaccines, BCG, and then yellow fever. All other vaccines can be given including measles, mumps, rubella. Whereas in asymptomatic HIV, with a CD4 count of more than 15%, all vaccines can be given. All vaccines can be given. Only 2 vaccines are not given in symptomatic HIV patient, BCG and yellow fever, whereas all vaccines can be given in an HIV patient including measles, mumps, rubella, provided the CD4 count is more than 15%. Tidbit number 1. Tidbit number 2. What are all the other tidbits number? When you take oral steroids, how long you are not supposed to give? When you give oral steroids, how long you need to postpone your live vaccine? Oral steroids. Answer anyone? Oral steroids. Yes, waiting for my kids to answer. Oral steroids. 2 2s are 4 formula, you remember, my dear boys and girls. When you give 2 mg per kg per day for more than 2 weeks, you are not supposed to give any live vaccine for the next 4 weeks. Someone had written, Neelam Bhatia had written except OPV. Neelam Bhatia, it was carefully written, OPV is not a contraindication, but IPV is preferred. I repeat, Neelam Bhatia, it was a beautiful explanation. OPV is not contraindicated, but IPV, if available, please go for IPV vaccine. It is not a pure contraindication, ma. Okay. Now, when you give 2 mg per kg per day for more than 2 weeks, avoid vaccination for the next 4 weeks. Avoid live vaccines for the next 4 weeks. Right. When you are in chemotherapy, radiotherapy, when you are receiving chemotherapy, when you are receiving radiotherapy, how long you need to avoid live vaccines? Chemotherapy or radiotherapy, how long you need to avoid your live vaccines? How long you need to avoid your live vaccines when you take chemotherapy and radiotherapy? The answer is, anyone? Chemotherapy and radiotherapy, how long you need to avoid your anyone? I am waiting. 1 month. Is it correct, ma? 1 month? My dear kids, is it 1 month, Raja? No, it is 6 months. It is 6 months. It is 6 months. If you are receiving chemotherapy and radiotherapy, the answer is 6 months. Don't give any live vaccine. It is 6 months. Only vaccine that can be given, only vaccine that can be given during that period, that can be given during chemotherapy or radiotherapy. Anyone? Chemotherapy or radiotherapy? Yes, the answer is influenza. Influenza vaccine is the only vaccine that can be given even during chemotherapy and radiotherapy. Okay. Therapy and radiotherapy. Right. Chemotherapy and radiotherapy. Okay. So vaccine, that's it. We have a short time. We will now go to nutrition. What are all the important topics with respect to nutrition? My dear boys and girls, child with the following sign can have the following. Don't worry about copyright images. This is my ward case. This is our ward case. Okay. What are all the signs? Anyone? What are all the signs? Let my kids see this picture clearly. Then they can answer. Then they can answer. What are all these two signs? Tell me. Waiting for my kids to answer. What are all these two signs? The boy on the right. What is this? Look at his face. And look at his thighs. Look at his face and look at his thigh. Answer. Anyone? Yes, I agree, ma. What is this sign called as? Arunan, it is protein energy malnutrition. I agree, Arunan. What is this sign called? Absence of subcutaneous fat. Unborn cell. No, my dear. Absence of subcutaneous fat in the face. Very good. Yuvaraj Gohil, very good. Taranka, very good. Absence of subcutaneous fat in the cheek is called as monkey faces. Very good, pa. This is called monkey faces. Often asked question. Monkey faces. And what is this? Wiki Smart. Wiki Smart. He himself is calling her. No problem. What is this? Absence of subcutaneous fat in the gluteal region. Called as baggy pant appearance. Very good. It is called as baggy pant appearance. It is called baggy pant appearance. Pant appearance. Appearance. My dear boys and girls, okay, this baggy pant appearance and monkey faces are features of, is it marasmus or kwashiorkor? Is it marasmus or kwashiorkor? Baggy pant appearance and monkey faces, is it marasmus or kwashiorkor? Can anyone tell me what is the difference between a marasmus and a kwashiorkor? I am waiting for my children to answer. Is it marasmus or kwashiorkor? In what is this? Monkey faces, loss of subcutaneous fat in what is that? Gluteal region, absence of subcutaneous marasmus. So marasmus is nothing but wasting. Wasting of what? Subcutaneous fat. When you have this two signs, when you have these two signs, that is baggy pant appearance and monkey faces, then it means you are dealing with a case of marasmus. Marasmus is energy deficient, carbohydrate deficient diet, as a result of which your subcutaneous fat is utilized. Ashish Rajput, very good. Energy deficient. Joshi, correct. Marasmus is calorie deficient. Correct. Okay, now let us go to it. Which child with the following sign can have the following? What is this? The signs are monkey faces and baggy pant appearance. Protein deficiency, no. As my children has been answering, it is energy deficient. Marasmus child usually will have voracious appetite. So poor appetite is also wrong. When you are not taking anything for about months together, when someone is giving, definitely you will eat. Yes, good appetite is the answer. Whereas apathy, dullness is a feature of kwashiorkor. I repeat, your protein deficiency, poor height and apathy and anorexia are features of protein energy malnutrition. Here we saw a case of marasmus with the monkey faces and baggy pant appearance. It is characterized by voracious appetite, Neelam Bhatia. Very good. Then, okay, answer is Sida. Very good, Ra. Okay, then, what is this? What are all these signs called as? What are all these signs called as? Again, the one on the left side is what? I need to thank my brotherly friend Dr. Ashwath for providing this image. The one on the right side belongs to us. What is the one on the left side and what is the one on the right side? What is this and what is this? Answer me. Flax sign, Shifana, Nailam, flax sign. Okay. The answer is easy. It is called a flax sign. Very good, pa. It is called a flax sign. And what is the one on the right side? Very good. Osama Joshi, flaky paint dermatosis. It is flaky paint dermatosis. This flaxine and flaky paint dermatosis are features of dash. Are features of dash. What? Yes, very good. Are features of what? Kwashiorkor. Features of Kwashiorkor. Kwashiorkor is mainly what? Protein deficient. This protein deficiency in turn leads to what? Albumin low values. This in turn leads to pedal edema. Remember, loss of proteins leads to mental apathy, and the loss of protein leads to increased infection. Protein leads to increased infection. Okay, increased infection. This is the pathogenesis behind protein energy malnutrition or kwashiorkor. When you see this flaxine, when you see this flaky paint dermatosis, you are dealing with a case of predominant protein loss leading to hypoalbuminemia, infection, pedal edema and mental apathy. Here appetite will be very, 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 very bad. Because of the absence of albumin, the body tries to produce, the liver tries to produce proteins, but instead of albumin, it secretes some other protein, as a result of which, as Neelam Bhatia told, hepatomegaly is a feature of kwashiorkor. So the child with the following can have the following. Child with the following sign means child with kwashiorkor can have the following except protein deficiency. My kids will answer just like that. Yes, it is there. It will be there. Poor appetite. Kwashiorkor is characterized by mental apathy and poor appetite. Yes, it will be there. Pedal edema is a characteristic feature of kwashiorkor. Yes, it is there. And as Neelam Bhatia mentioned, hepatomegaly is a feature of kwashiorkor. Early response to therapy, is this correct or wrong, my dear boys and girls? Marasmus will respond early to treatment because there are less complications. Whereas whenever you have features of kwashiorkor, they are more prone for infections, more prone for complications, as a result of which you won't get early response. It is late response to therapy. Okay, Yuvaraj, very good, very good. My kids are answering very good. So the answer is D. That's it. A small revision, rapid fire 1 minute revision. Answer with me, my dear boys and girls. Answer with me. Marasmus is characterized more common between 6 months to 1 year. Predominantly the deficiency is calorie, whereas kwashiorkor is common between 1 to 5 years. Predominant deficiency is protein. So edema is more common in kwashiorkor. You won't get edema in case of marasmus. Activity. Voracious appetite. We will be sending you the telegram for discussion. Don't worry, we will be working as a team. You will be from tomorrow, my dear boys and girls, from tomorrow. Activities, yes, superb activity. Sluggish, apathy is a feature of kwashiorkor. Appetite, voracious in case of marasmus, very bad appetite in case of kwashiorkor. Liver enlargement, yes, it is a feature of kwashiorkor, not a feature of marasmus. Mortality, kwashiorkor is more prone to develop mortality. Yes, it is a feature of kwashiorkor. Here, no, mortality is not that common. Neither mortality nor morbidity. neither mortality nor morbidity. Yes, finally, recovery. Recovery is rapid in case of marasmus, slow in case of kwashiorkor. Immunoglobulins are lost. Immunoglobulins are lost. So, infection is more common in kwashiorkor, less common in marasmus. Peculiar features, just now we saw, my dear boys and girls. Peculiar features either here is baggy pant appearance and then monkey faces and then monkey faces. Whereas peculiar features are flaxine. Why this flaxine? During periods of good nutrition, pigmented hair. During periods of bad nutrition, depigmented hair. That's why you get flaxine. And then flaky paint dermatosis. Flaky paint dermatosis. Is it okay, my dear boys and girls? Is it okay? How long? How many hours of session? As long as you tolerate, I will continue. Okay, right. What is the right now? Are we using this classification? Right now, are we using this classification? Marasmus and kwashiorkor? No, my dear boys and girls. We are incorporating the features of marasmus and kwashiorkor. I repeat, we are incorporating the features of kwashiorkor and marasmus. So, what does it mean? When you have features of marasmus alone, it is called as marasmus alone. You will call it as moderate malnutrition. When you have features of edema, that is the feature of kwashiorkor, you will call it as severe acute malnutrition. So what does it mean? What does it mean? We are taking three things, my dear friends. This is very important for your MCQ. We are taking three things as far as the new WHO criteria. What are all the three things? Edema is present or not. Whenever edema is present, it means it is more prone for complication because it is a feature of kwashiorkor. Right now, we do not call as marasmus or kwashiorkor. We call it as protein energy malnutrition. Weight for height and then height for age. Why weight for height has been included? Weight for height included because it indicates acute malnutrition. Acute malnutrition. When height for age is affected, it is over a period of time. It is called chronic malnutrition. Height for age, chronic malnutrition. Remember, if your weight for height or height for age is between -2 to -3 standard deviation, it is called moderate acute malnutrition. Whereas if your weight for height and height for age is less than severe -3 standard deviation along with the edema, it is called as severe acute malnutrition. Okay, so weight for height is meant for acute malnutrition, that is wasting. As someone told, height for age is affected, it is chronic, it is called stunting. Your protein energy malnutrition includes both wasting and stunting. If it is -2 to -3 standard deviation, moderate. If it is more than that, it is severe. If edema is present, it is severe. Okay? Most important MCQ of nutrition. Students, now answer. Most important point. All of the following is correct regarding the diagnostic criteria of severe acute malnutrition except. Waiting for my kids to answer. All the following is correct regarding the diagnostic criteria of severe acute malnutrition except. Waiting for my kids to answer. Yes, answer B. Except. It was told to my boys and girls that they incorporate the features of marasmus and kwashiorkor. Except B. What happened to you? What happened to you? Aruna, Kavi, Osama, what happened to you? Severe acute malnutrition. Just now. Answer is C. What happened, my dear boys and girls? Vicky Smart is relatively smart. Let us see. Yuvaraj Godel. Capricorn, I am little bit worried. What is this? Just now we saw the definition. Shall I go back to the original slide? Severe acute malnutrition. Original slide. Yes. Now you answer. Now you tell me what is the answer. Lakshmi Krishnan, correct. I don't know. Vicky Smart, correct. Joseph, correct. I don't know. I have shown you the answer chart. Now you tell me, wasting is there? Yes, it is included. Edema is there? Yes, it is included. Answer is, edema is there? Yes, it is included. Look carefully. Is it weight for height or weight for age? What happened to my dear boys and girls? Look carefully. It is weight for height and not weight for age. Going back to the question, read it carefully. It was taught to you. The new definition for severe acute malnutrition is Capricorn. A, I think A is the answer. Joseph, Lakshmi, Capricorn. Very good, Ra. Okay, this is how you will miss certain diagnosis. This is how you will miss certain simple questions, ba. Look here, it is not weight for age. It is weight for height. This is how my kids will be deceived in the entrance examination. Okay, weight less than -3 standard deviation. Yes, correct. Visible wasting. Yes, marasmus they had included. Marasmus wasting is nothing but weight for height, not weight for age. Edema. Yes, edema is included. Mid-arm circumferences less than 11.5 centimeter. Mid-arm circumference less than, yes, 11.5 centimeter. Answer is A, boss. A, my dear boss. It is weight for height and not weight for age. Again, yeah, mid upper arm circumference of less than 11.5 centimeter is severe acute malnutrition. And your mid upper arm circumference of 11.5 to 12.5 centimeter comes under moderate acute malnutrition. An answer to a tidbit to add here. ठीक है भैया? ठीक है, my dear boys and friends. Why mid-arm circumference is chosen? Because it is age independent criteria. It is age independent criteria. Throughout from 6 months to 5 years, it is the same. That's why it has been employed. That's why it has been employed. Mid-upper arm circumference. Mid-upper arm circumference. Again, I need to thank one of my friend for giving this picture. Wait for, I repeat what I need to write, my dear boys and girls. What I need to write? Wait for height. And then it is -3 standard deviation. Visible severe wasting. Presence of bipedal edema. Mid-arm circumference of less than 11.5 centimeter. Look here, the child hair in this picture. Yes, there are some hair changes. There is some edema. So this is severe acute malnutrition on treatment. Severe acute malnutrition on treatment. Okay, what is this? Now you tell me, common to both acute and chronic malnutrition is weight for height, height for age. Weight for height, wasting. Height for age, stunting. Weight for height, acute malnutrition. Height for age, chronic malnutrition. Whereas weight for age, again you did a mistake. Weight for age is acute on chronic malnutrition. Acute on chronic malnutrition. Acute on chronic malnutrition. The answer is A. Yes, Bansal, the answer is A. Again, very important with respect to wasting acute malnutrition, weight for height. Stunting chronic malnutrition, height for age. Weight for age is acute on chronic malnutrition. Yes, good. While going back to the treatment, all the following should be given orally or through NG tube on day 1 of admission of severe acute malnourished child. 8th question. All the following should be given orally or through NG tube on day 1 of admission of SAM child except. Yes, waiting for your answer. Except folic acid, vitamin A, magnesium sulfate, iron. I will be waiting for my kids to answer. I will give you 10 seconds. Remember day 1. Remember NG tube or oral route. Osama goes for iron. Vicky goes for iron. Yuvaraj goes for iron. All goes for choice D. Very good. All goes for choice D. I accept, my dear boys, because you can give folic acid, vitamin A. Folic acid is oral route, vitamin A is oral route. My dear boys and girls, magnesium sulfate is IM. Magnesium sulfate is IM. I know my kids will answer iron. Just to make a small confusion, I had added that oral or NG tube. So on day 1, you are not going to give iron. Iron is given in the rehabilitation stage. Given in the rehabilitation phase, that is after 7 days. Magnesium sulfate is given on day 1, but it is not oral, it is iron. Here the question is oral or NG tube, NG route. Even though a little bit of difficult, I agree with your answer on iron. I agree with the concept of understanding iron therapy, but magnesium sulfate is given through IM route. So both answer C and D are except because it is through oral route. But let it be, my dear boys and girls. If you opted for D, we will be giving you full marks. But remember, just to make you sure that magnesium sulfate is given through IM route. Done. IM route. Done. A small point on IM route. Can anyone tell me? Can anyone tell me a rapid tidbit fire round? A rapid tidbit fire round. You are going to treat hypoglycemia. Define hypoglycemia. You are going to treat hypothermia. Define hypothermia. Define hypothermia. Just yes. Levels, yes. You are going to treat hypoglycemia. What is hypoglycemia? You are going to treat hypothermia. What is hypothermia? Just mention what the value. I am going out of the question. What is the value? What is the value? Hypoglycemia. Very good. Hypoglycemia means less than 54 milligram per deciliter. How many of you had answered 54 milligram per Neelam? Correct. Taranka Das, no. It is 54 milligram per deciliter. It is not 45. It is 54. And then hypothermia. It is 36.5. Many are confusing with the newborn question. It is not rectal temperature. Osama bin Laden. Osama said it is not. I'm sorry. Osama said it is not rectal draw. Thanks for making me to say it is axillary temperature. It is axillary temperature. Osama, thanks for remembering me. It is axillary temperature. Many of you are getting confused with the neonatal temperature chart. Okay, hypothermia means whether it is mild or whether it is severe. Mild to moderate. Mild hypothermia means, my dear boys and girls, Osama, very good. 35.5 Daraja, 35.5 degrees Celsius. Back with a bang. Axillary temperature of less than 35 degrees Celsius. Very good. What is severe? Samantol, Yuvaraj, Liffels. Very good, ma. Value of less than 32.5 nahi hai. It is 32 degree Celsius. It is 32 degree Celsius. I thought you will be answering correct. Okay, let it be. It is a revision session. Okay, so make sure in severe acute malnutrition it is less than 54 milligram per deciliter hypoglycemia. Mild hypothermia is 35 degrees Celsius and severe hypothermia is 32 degrees Celsius. Okay? Done. Another one more beautiful MCQ. Another one more beautiful MCQ. What is the choice of fluids in severe dehydration? Choice of fluid in severe dehydration. In severe dehydration. Another important MCQ of INICET and NEET. What is the choice of fluid? Choice of fluid in severe dehydration correction. Waiting for my kids to answer. Choice of fluids in severe dehydration. 10% DNS. Then 10% DNS. Only dextrose is sufficient. RL, SK, RL, Lakshmi, RL, Vicky, RL. Let me write. You can give RL, choice 1. You can give off normal saline with dextrose. It is not 10% Raja, it is 5%. Another mistake, it is 5% dextrose, it is not 10%. Third one, RL, off normal saline with 5% dextrose or RL with 5% dextrose. Dextrose, very good. Okay, Sandeep must have been practicing somewhere else. Isolate P, we are not giving all those things, my dear boy. Okay, RL with 5% dextrose. What is the dose and how long? That is where our MCQ stands. What is the dose and how longs? What is the dose and how long? Severe shock, severe acute malnutrition, child presenting with severe dehydration. What is the dose? Fluid calculation. Arunan, fluid calculation. My dear boys and girls, be very, very careful while treating a child with severe acute malnutrition. Whenever you see a kid with severe dehydration, you will give 100 ml per kg. In case of a normal child, yes, get caught Taranka, you are get caught 100 ml per kg. Here it is severe acute malnutrition. When you do such kind of fast correction, the child will die of electrolytic disturbances. Electrolytic disturbances. So what is the answer? It is, I repeat, listen carefully my dear boys and girls, it is 15 ml per kg over 1 hour. 15 ml per kg over 1 hour. It is 15 ml per kg over 1 hour. All are wrong. It is 15 ml per kg per 1 hour. It is 15 ml per kg per 1 hour. Okay? Now, severe dehydration correction. This is the rehydration correction for severe acute malnourished children. Since many of you have opted for some 100 ml per kg, in normal child, what is the dehydration correction? I am not going to say right now because we are going to discuss IMNC topic. I will explain that. But as of now, my kids should remember that in severe acute malnutrition, the correction is 15 ml per kg over 1 hour of RL or off normal saline with 5% dextrose or RL with 5% dextrose. Okay? Dextrose. Right, what is the answer? A 3-year-old, look at this. A 3-year-old female child weighing 6.5 kgs, presents with signs of shock, tachycardia, fast breathing, feeble peripheral pulses. What is the treatment? I am going to wait for the next 10 seconds what my children are going to answer. Let me see. What my children are going to answer, let me see. I am waiting. Just now it was taught to my boys and girls. Tell me, a 3-year-old child weighing 6.5 kgs, 3-year-old 6.5 kgs, the answer itself says it is severe wasting or severe acute malnutrition. So what is the answer? TD has answered C. I am waiting for 2 more answer. My kids are fine. My kids are fine with the concept right now. Good. It is 15 ml per kg. So 15 into 6.5, 100 ml per kg of 5% dextrose over 1 hour. My kids have understood the concept. Thank you. Then the last question, an often asked question on INICET for the more than 2 to 3 decades with respect to protein energy malnutrition. I'm sorry. What is this? A 3-year-old child with severe acute malnutrition. Severe acute malnutrition itself indicates edema. Is being managed as an inpatient. All severe acute malnutrition with edema should be managed as an inpatient. Whereas without edema or without medical complication can be managed as home care. I repeat, in the hospital for the past 15 days. The child had no edema from day 6. That means the child had been responding to the treatment and started gaining weight of 10 gram per kilogram per day. It means that the child has been responding to the treatment well. Now the child suddenly developed abdominal distension, hepatosplenomegaly, parotid swelling, tremor and gynecomastia. This question was asked to me in the year 2002. Since then I have seen more than 6 to 7 times this question have been asked. Answer. What is this syndrome called as? What is this syndrome called as? TD option B, Yuvaraj option C. What is this syndrome called as? Step up proteins. Why, my dear boys and girls? Why? Osama B, Neelam B. Luckily, I have opted for certain questions that is going to make a big difference to my boys and girls. Majority are opting for wrong answers. Wrong answers. So let it be. Life is a process of continuous learning. There are 2 types of complication. Listen to me, my dear boys and girls. There are 2 types of complications. There are 2 types of complications can occur. The first come Ansh Bansal refeeding syndrome. Let me see Ansh Bansal whether you are correct or wrong. First one is increased calorie. You need to give what calorie pa? You need to give F75 calorie and then you need to go for F100 calorie. Start low calorie. Start low calorie. You need to start low calorie and you need to start low protein. You need to start low protein. Low calorie and you need to start low protein. That's why F75 to F100. F75 contains 70 kilocalories per 100 ml along with 0.9 gram of protein per 100 ml. This is F75 formula. Initially, during the first 2 to 3 weeks, we start with the F75 and then gradually we go to F100. F100 contains 100 kilocalories per ml along with 3 grams per 100 ml. You need to be cautiously increase your calorie as well as increase your protein. When you give more and more calories during the initial part of the treatment, that is during the stabilization phase, if you give more and more F100 formula, what will happen, my dear boys and girls? What will happen? That is refeeding syndrome. What is refeeding syndrome? Giving more and more, this is called refeeding syndrome. Wait, this is called refeeding syndrome. Refeeding syndrome is giving more number of calories than required during the initial phase, that is stabilization phase. What is this refeeding syndrome? This is not refeeding syndrome. Let me tell you what is this refeeding syndrome. When you give more and more calories than required, for example, you give 100 formula rather than F75, it will increase sodium pump. Giving more calories during your stabilization phase. What is that phase? Stabilization phase. More and more calories, it will improve your sodium pump. What will happen? This sodium pump in turns absorbs glucose, potassium, magnesium, phosphate from the extracellular compartment to intracellular compartment, leading to hypoglycemia, hypokalemia, hypomagnesemia, and hypophosphatemia. I repeat, this glucose, potassium, magnesium, and phosphate are absorbed from the extracellular to intracellular compartment, leading to hypoglycemia, hypokalemia, hypomagnesemia, and hypophosphatemia. And sodium will be ejected into the ECF. Sodium will be ejected into the ECF, leading to edema, and leading to severe electrolytic disturbances. Severe electrolytic disturbances. This is called as refeeding syndrome, my dear boys and girls. Refeeding syndrome is due to more calorie during stabilization phase. Among all, what is the most common MCQ that can be asked throughout the world, even whether it is USMLE, NEET, INICET? The main importance they are giving to hypophosphatemia. I repeat, the main importance they are giving to hypophosphatemia. Finally, what is the treatment of choice? Treat edema. The treatment is a single dose of digoxin and furosemide. Treatment is single dose of digoxin and furosemide. This is called as refeeding syndrome. I am happy that I am teaching something new, but often asked question, but a confused thing with respect to entrance MCQ. Refeeding syndrome is due to more and more calorie during the stabilization phase, leading on to increased sodium pump, leading on to edema, and then it also absorbs sodium, potassium, magnesium, phosphate in the intracellular, leading to severe electrolytic disturbances. The main entrance MCQ is hypophosphatemia. Treatment is your digoxin and furosemide. Okay? Right. Thank you, Sachin. Digoxin and furosemide. Next, then what is this, my dear boys and girls? Here there is nothing related to refeeding syndrome in our question. Look at this. Here I have parotid swelling, tremor, gynecomastia, hepatosplenomegaly, everything not at all related to refeeding syndrome. Anshu, Capricorn. But I am happy that my kids know something about refeeding syndrome, which is often asked. Refeeding syndrome is edema, electrolytic disturbances, high calorie during stabilization phase. Whereas the one that we are mentioning here is called as nutritional recovery syndrome. What is that called as? Nutritional recovery syndrome. Okay. This question was asked for me 20 years back. Since then, they have been asking this question because you have a little bit of confusion within refeeding syndrome and nutritional recovery syndrome. Nutritional recovery syndrome usually due to very high quantity of proteins. Let me change the color. Proteins during what? Not stabilization phase, rehabilitation phase. Rehabilitation phase. This increased protein leads to stimulation of pituitary gland, which in turn secretes estrogen. This estrogen is responsible for all endocrine disorders. Your hepatosplenomegaly, tremor, parotid swelling are all due to increased estrogen. I repeat, my dear boys and girls, refeeding syndrome occurs initially because of increased calorie during stabilization phase characterized by edema, electrolytic disturbance. Treatment is digoxin and furosemide. Whereas your nutritional recovery syndrome is characterized by increased protein during rehabilitation phase, leading to stimulation of pituitary, stimulation of estrogen, leading to endocrine disturbances, parotid swelling, gynecomastia, etc. Treatment here is step down the protein. So what is the answer for our question? What is the answer for our question? Tell me, what is the answer for our question? So is it refeeding syndrome or nutritional recovery syndrome? Our question, the refeeding or nutritional recovery syndrome? Waiting for my children to answer. No one is answering, or is it? Okay, so here hepatosplenomegaly is there. Healthy pill, what happened? Here, look here. B is step up protein. It is due to high protein. Healthy pill, what happened to you? So step down protein is the choice. Step down protein is the choice. Okay? Right? My kids have understood, including my healthy pill. Okay. Right, nutritional recovery syndrome. Now my kids know clearly about nutritional recovery syndrome as well as refeeding syndrome. Okay, baby? So thumbs up if you really understood the concept behind a nutritional recovery syndrome and refeeding syndrome. Okay, thus done. The following is true about ORS. Anyone waiting for your answer? These are all common small topics. Often you will not be concentrating on general pediatrics, which includes your newborn, nutrition, vaccination, immunization, IMNCI. But here you will miss the bus, because majority of the systemic pediatrics, even though we have some difference, you can think and answer based on your knowledge gained from our medicine faculties. But here you need to understand the concept of general pediatrics. Pediatrics is not miniature adult, my dear boss. Answer. Thus, following are true about ORS. ORS. I am waiting for my kids to answer. Standard ORS and then rhizomol. Standard ORS and then rhizomol. What is the osmolarity? What is the sodium? What is the potassium? What is the sugar? Come on. Come on. Answer me. Answer this, then we can go to the discussion per se. Discussion per se. The following are true about ORS. Many have answered. Okay. My kids are going to answer this. What is the osmolarity of standard ORS? Standard ORS. Let me complete standard ORS. Standard ORS is 245 millimole per liter. Sodium is 75, sugar is 75, potassium is 20. But what happens in, is it okay, my dear boys and girls? But what is rhizomol? Rhizomol is rehydration solution for malnourished children. Rhizomol is rehydration solution for malnourished children. What happens in rhizomol? Are you going to give this standard ORS? No, my dear boys and girls. What happens in severe acute malnutrition in which you use rehydration solution for malnourished children? How you are, what is the problem behind the severe acute malnutrition? They will have less sugar. They will have less sugar. They will have less sugar. They will have more sodium retention. They will have less sugar. The problem with respect to severe acute malnutrition is sugar will be less. They are prone for hypoglycemia. They will have more sodium in the body. They have more sodium in the body because of chronic diarrhea. What is this? 3000 I know. Okay, what is this? Because of potassium loss, chronic diarrhea, they will have low potassium. Potassium. What else? Now you tell me, what will be the management of choice in severe acute malnutrition? How you will convert? Can anyone tell me how standard ORS is converted to? How standard ORS is converted to this Risomol? Can it be converted? Entrance MCQ once asked in JIPMER when it was there. Sugar is low, sodium is high, potassium is low. How you are going to convert? Joseph. Joseph is very good, my dear boy. How you are convert? Joseph is saying you need to increase the glucose. Let me write. So sugar should be increased. From 125 in Risomol, it has to be increased to, I am happy with Joseph, 125. Increase the sugar. Chronic diarrhea leads to hypokalemia. Increase the potassium to 40. Potassium to 40. And then sodium has to be decreased from, because they have sodium retention, to again to 45. Remember, you are adding more and more glucose so that the osmolality is increased to 300. My dear boys and girls, Risomol is often asked question in your entrance. As Joseph clearly mentioned, it is 300, 45, 40 and 125. Now tell me, Joseph, how you are going to convert this ORS into Risomol? How this can happen from here to here? Very, very simple. How many liters of water should be added to ORS? Can anyone tell me? Normally, 1 sachet of ORS should be added with dash liter of water. Dash liter of water. Waiting for my kids to answer. Waiting for my junior friends to answer. Normally, ORS will be mixed with dash liter of water. Normally. What happened, Ra? Any network delay? 1 liter, 1 liter, 1 liter. Okay, agree. 1 liter. But here you need to, here in Risomol, you need to reduce the sodium content. So, ORS plus 2 liter of water. Entrance MCQ. So, sodium will be reduced. Second, add sugar. 50 gram of sugar. Add potassium. 50 ml of pot chlor syrup. My dear boys and girls, this is how you will make. Why, Yuvraj, Goli, you are making it more and more concentrated, Ra. ORS plus 2 liter of water plus 50 gram of sugar and 50 ml of pot chlor syrup will convert my standard ORS to Risomol. Okay, my dear boys and friends? Okay, right. Now you tell me the answer. The following are true about ORS. Osmolality is maximum in Risomol. Maximum in Risomol? No. Your standard ORS, the old ORS which was meant for cholera, has been replaced right now, because in cholera you have more and more sodium loss, more and more electrolyte loss. But now we have been seeing so many rotaviral viral diarrheas in which the osmolality is not that great. So the standard ORS of 311 has been reduced to 245 as many mentioned. Osmolality is maximum where? Osmolality is maximum in old ORS, conventional ORS. So this is wrong. Glucose is maximum in standard ORS. My friends, glucose is maximum where? Where we need to add more and more glucose. Yes, very good. Rhizomal. Again, this is also wrong. Glucose is maximum in rhizomal. How much? You are adding how much? Glucose 125. How much? 125. Third, sodium is minimum in rhizomal. The answer is yes or no. It is 75 in case of low osmolar, 90 in case of standard, reduced to 45. So sodium is minimum in rhizomal. The answer is correct. Old ORS 90, new ORS 75, rhizomal 45 or 40. Okay. Finally, potassium is maximum in standard ORS or no? It was 20 in standard, 20 in case of new ORS, but it has been increased to 45 in case of rhizomal. Again, potassium is maximum in rhizomal. Finally, copper and zinc in low osmolar. No, only children with the protein. What happened? Yuvraj, what happened? Copper and zinc in low osmolar ORS. Copper and zinc are necessary while treating a child with protein energy malnutrition. It is not old ORS, it is rhizomal. So this is also wrong. This is more in rhizomal. So what is the answer? The answer is C only. The answer is C only. Let me show it clearly right now. If you want to take a screenshot to revise, you can, or else put every point in hippocampus directly and teach your boyfriend or girlfriend so that you can remember. That's it. What are all the MCQ? Osmolality is 300 for rhizomal. Glucose has been increased to 125. Sodium has been decreased to 45. Chloride, I don't think you will get a question. Potassium has been increased to 40. That's it. Okay, baby. Despite all this, why C and E, your copper and zinc are more in protein energy in rhizomal. It is not in standard ORS. Have you taken a screenshot? Even if it is not, don't worry, we will be giving you PDF. Our PW team is working on it. We will be giving you PDF. Is the concept clear, my dear boys and girls, with respect to ORS? Is the concept clear? If it is yes, okay, let me go to the next question. Say yes. Give me a thumbs up if you understood the concept. Sodium has been increased from old 125 to 75. Now it is 45. Potassium 20, old 20, new, increased to 40. Glucose 111 reduced to 75 in new ORS, increased to, very good, increased to 125 in case of rhizomal. Okay, baby, one short MCQ from this. Okay, okay, done. Next, done. I am happy. Okay. Next question. What is this question? 12. Let my kids read the question. A 4-year-old child brought with 3-day history of fever, cough, and presented with the following. What is this presented with the following? Let me say. The child takes feeds. That the child is able to take feed. No stridor or refusal of feeds. As per INICET, the following is true. Sir, the child is presented with the following. What is this following, sir? You didn't show me anything. Let me show you the video which was taken in my clinic 1 week back. Without seeing, how can you answer, Ra? See what I am going to show you. Okay. Okay, is it visible, my dear friends? Is it visible? What is there you are seeing? This video was taken just a week back in my clinic. Again, do you want to repeat? Okay, let my kids see what is the real is not running. Treatment started even without the video. This is a real scenario, boss, not your entrance MCQ. Have you seen? What is this you have seen? What is this you have seen? Retractions. My dear boys and girls, instead of using the term retractions, choose the word chest in drawing. Choose the word chest in drawing. Instead of using the term retractions, use the word chest in drawing. This is what they have been using in IMNCI. Chest in drawing. Okay, baby, let us go to the question. Let us go to the question. So, this is the question. So, tell me what is the answer. Now tell me, a child with the tachypnea, a child with the indrawing, a child with the trachypnea. Now, not only this for entrance, boss, whenever you see a child with this kind of chest indrawing, you need to be careful while treating the child. Okay? Start antibiotic and refer homemade remedies, rule out TB. Lakshmi opted for A. Healthy pill opted for A, Capri B, Neelam B, Smarty A. We need to tell you, da. Okay. Refer, guys. Capricorn must be working in a village. Whatever the case comes, refer. Capri, what happened to you, ma? Okay, let us see. Sandeep Kumar, A, B. Okay. Let us go to the answer. The recent ARI control program, I repeat, my dear friends, the recent ARI control program is this. You need to see respiratory rate, you need to see chest indrawing, and you need to look for danger signs. And you need to look for danger signs. You need to look for danger signs. Okay. Respiratory rate, chest indrawing, danger signs. Right? And danger signs. When tachypnea is there, but no chest indrawing, no danger signs. Sir, what are danger signs? Let me tell you. What are danger signs? Danger signs are 1. Stridor in a calm child. Stridor in a calm child. Stridor in a calm child. 2. Bus, listen here. Okay. Stridor in a calm child. 2. Not taking feeds. Taking feeds. 3. Convulsions or history of convulsions. 4. Vomiting everything. 4. Vomiting everything. Vomiting everything. Okay. Vomiting everything. These are all the general danger signs. My dear kids, what are all the 3 parameters my children are going to see? Not taking fits and lethargy are one and the same, Capri. Okay. Respiratory rate, chest indrawing, danger signs. When respiratory rate is more, there are no chest retraction, no danger sign. This is called fast breathing pneumonia. This is called fast breathing pneumonia. This is called fast breathing pneumonia. Now, right, skin pincher. I am talking about pneumonia, da, not diarrhea. Da. Ayo, God. Okay, let it be. Right. Fast breathing pneumonia. Second one is when you have fast breathing, when you have fast breathing as well as chest in drawing. Right now, my kids have seen what is called chest in drawing, but there are no danger signs. This is called chest in drawing pneumonia. This is called chest in drawing pneumonia. And finally, when you have fast breathing, chest in drawing, and when you have danger signs, it doesn't mean that you need to have this. When you have danger sign, it is called severe pneumonia. It is called severe pneumonia. Severe pneumonia. Severe pneumonia. Now, 3 cardinal points: fast breathing, chest in drawing, danger signs. Now you tell me the classification of pneumonia. I am waiting for my kids to answer. Now you tell me the new ARI control 2014. 2014 I am saying new, no? It is before Christ. It has become almost 10 years. What is the new criteria for pneumonia? No, some severe. Sandeep Kumar Durve has said no, some severe. I am waiting for 2 more options. How do you classify pneumonia right now based on ARI control program? Waiting. How do you classify? Okay. Pneumonia is classified as no pneumonia. Okay, no pneumonia. Very good. Who is that? Leafless. Very good. Second one is pneumonia. Third one is severe pneumonia. Severe pneumonia. There is nothing called very severe. There is only no pneumonia, severe pneumonia. This pneumonia can be either fast breathing pneumonia or chest in drawing pneumonia. That's why chest in drawing pneumonia comes under pneumonia, because this chest in drawing and fast breathing pneumonia are treated home based. Can anyone tell me what is the treatment of choice? The treatment of choice is amoxicillin 80 mg per kg per day. But as per IMNCA, it is written as 50 mg per kg per day. IMNCA says 50 mg per kg per day, but a new adaptation says 80 mg per kg per day. How many days? For fast breathing pneumonia, 3 days. This is the new WHO criteria. Chest in drawing pneumonia, 5 days. What is this? This is 2014 WHO criteria. But as per IMNCI, it is 50 mg per kg per day of amox for about 5 days. For about 5 days. Chloramphenicol. Still you are in before Christ. He is still living in before Christ. Anand Verma. Chloramphenicol and all we are not using. Still you are in before Christ period. Okay, come out. Okay, now what is this? Severe pneumonia. Severe pneumonia is danger signs. Danger sign. Start and refer. What do you start and refer? if ampicillin and gentamicin are and then you refer, don't read, you refer. Okay, refer. Now you tell me what is the answer for my question. Now you tell me what is the answer for my question. Answer. A 4-year-old child brought with 3-day history of fever, cough, presented with, it was shown to you, tachypnea and chest in drawing. It was shown to you tachypnea and chest in drawing. So it comes under what? Chest in drawing pneumonia comes under non-severe or severe? Comes under non-severe or severe? Comes under non. Very good. So start antibiotic, no need to refer. Antibiotic, no need to refer. Start antibiotic and refer in case of danger signs. There are no danger signs. Home remedies, no fast breathing, no chest in drawing, no pneumonia, no danger signs. When will you rule out TB? When here the duration is 3 days. When cough lasts for more than 2 weeks, rule out TB. Rule out TB. My dear boys and girls, last but not least, my kids know defined tachypnea. My kids know defined tachypnea. My kids know defined tachypnea. What is called tachypnea? A respiratory rate of more than. So what is the definition? Tell me. Less than 2 months, what is called tachypnea? 2 months to 1 year, what is it? 1 to 5 year, what is it? 1 year to 5 years, what is it? What is it? Very good. Less than 2 months, more than 60 per minute. These simple questions you will be confused. 2 months to 1 year, more than 50 per minute. And 1 to 5 years, more than 40 per minute. This you need to know with regard to 60, 50, 40. Less than 2 months, 2 months to 1 year, 1 to 5 years, 60, 50, 40. Okay, baby. Pneumonia, if it comes, my children will just do it like anything. That's it. 60, 50, 40. Okay. Right. So this, again, what is this? Cough more than 4 weeks, rule out TB as well as asthma. Nowadays, all primary health centers under National Rural Health Mission has got all facilities including pulse oximeter. IMNCI 2017 adaptation says a saturation of less than dash needs referral. 2017 adaptation. Waiting for my kids to answer. Joseph, you are correct. It is less than 90%. Joseph, I love you, baby. It is not 93. As Joseph said, it is 90. Okay, Joseph. Done. Okay. Right. 92. No. Stop there. It is 90. The answer is over. Joseph is the only person who made it correctly. Thumbs up, Joseph. Thumbs up. Okay. Are you Joseph Vijay? No, na? Right. 88. Chumma, you will, sometimes you will put some other value. 88, 93 as per the, this is not Viva OC. This is entrance MCQ. It is, the answer is 90. This is not Viva OC. Okay. Sorry for using mother tongue. Okay. Right. UV, good. Let's finish with this. Dehydration correction. Tell me, what are all the dehydration correction? Okay, what is the dehydration? 2 months to 5 years. Diarrhea, what are all the things? What is called severe dehydration? What is called some? What is called no? Even though these are very, very, very simple things, you need to know what it is. Okay, what is called severe? What are all the things that you need to see whenever a case of diarrhea comes? Whenever a case of diarrhea comes, waiting for my kids to answer. Again, in pneumonia, no pneumonia, pneumonia, severe pneumonia. In the same way, no dehydration, some dehydration, severe dehydration. What are all the things you need to see? General well-being in case of some no dehydration, it is alert. It is alert. In case of some dehydration, the child is irritable. Whereas in case of severe dehydration, lethargy. Thirst in case of some dehydration, it is normal. Whereas some dehydration, no dehydration, it is normal. Some dehydration, drinks eagerly. Very, very important point. Drinks eagerly. Many of you are concentrating only on skin pinch. You people need to concentrate on general well-being too. What is called some dehydration? Some drinks eagerly. Drinks eagerly. Whereas thirst, the child is lethargy, not taking feeds at all. Not taking. The child is sick to take ORS or water. Sunken eyes. It is not present here. It is present here. It is present here. It is present here. It is present in both some dehydration and severe dehydration. You need to have, when will you say dehydration? Among general well-being, sunken eyes and skin pitch, you need to have two or more of the following features. What are all the following features? General well-being, and thirst, one and the same. Sunken eyes and skin pinch. Someone told 3 seconds. I am sorry. Skin pinch goes back slowly or fastly? Let us see. Skin pinch goes back very slowly. Very slowly means, Osama, it is more than 2 seconds, ma. It is more than 2 seconds. Whereas in some dehydration goes slowly. Less than 2 seconds. No dehydration, very fast. You can't see that the skin is going. What are all the actions to be taken? What are all the actions to be taken, my dear boys and girls? What are all the action? No dehydration means plan A. Some dehydration means plan B. And severe dehydration means plan C. Now let my kids answer what is plan A and plan B and plan C. What is plan A? Waiting for my kids to answer. What is called plan A? What is called plan A? Waiting for my kids to answer. What is called plan A? Plan A means no dehydration. What is the treatment for it? Plan A means no dehydration. What is the treatment for it? Homemade foods. You can give ORS, no issues. ORS means replacement. Not correction pa, replacement. What is called a replacement? 10 ml per kg per stool output of ORS. 10 ml per kg per stool output of ORS. Along with home remedies, along with home remedies. Then, what is called plan B? Plan B is some dehydration. What is called plan B? Plan B is some dehydration. What is the treatment for? Oh, I need to go here. Okay. What is called some dehydration? Anyone? The same ORS, but here you are not replacing, you are Correction means what? It is 70 ml per kg of ORS over 4 hours. This is called plan B. This is called plan B. Plan B. Okay, some dehydration is 70 ml per kg of ORS over 4 hours. Plan B. What is plan C? Plan C is plan C. C means severe dehydration. My dear kids, here we have a caveat. Dehydration. Severe dehydration. Plan C. Over how many hours you need to say Lakshmi, tropocalcitonin. See, it is not tropocalcitonin, it is tropical capricana. Okay. So, what is plan C? Plan C is severe dehydration. What you need to give? You need to give 100 ml per kg of RL. It is divided into fast correction 30 ml per kg and then fast and then 70 ml per kg of slow correction. If it is child less than 1 year, I repeat, if it is child less than 1 year, then you need to be very careful. This 30 ml per kg over 1 hour and 70 ml per kg over 5 hours. So less than 1 year, slow correction over a period of 6 hours. 6 hours. Whereas if the child is 1 year to 5 year, it doesn't mean that, very good, it doesn't mean that you need to follow the slow correction. Fast correction, it can be 30 ml per kg over half an hour and 70 ml per kg over 2.5 hours. So it can be corrected over 3 hours. It can be corrected over 3 hours. Now you tell me, what is the treatment plan for severe acute malnourished child? This is for normal child. What is the treatment for severe acute malnourished child? I am expecting my kids to remember the points that we have discussed an hour back. Treatment for severe dehydration in SAM child. I am expecting my kids to put correct answer for severe dehydration in severe acute malnutrition. What is plan C in SAM child? What is plan C? Very good, Arunan, very good. It is 15 ml per kg per hour. 15 ml per kg per hour. Okay? Done? Yes, my kids are remembering. I am very, 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 very happy. Okay. What is called persistent diarrhea? What is called persistent diarrhea? What is called, very good, very good, very good, very good. I am happy. Okay. What is called persistent diarrhea? Tell me what is called persistent diarrhea. Persistent diarrhea means diarrhea lasting for more than dash days. It was there. Diarrhea lasting for more than dash days. Persistent diarrhea. 14 days. Yes, diarrhea lasting for 14 days. Whenever this persistent diarrhea is present, you see whether dehydration is present or absent. When dehydration is present, refer the child. When dehydration is absent, treat the child. Okay. Most often asked MCQ. Dehydration present with persistent diarrhea, refer the child. When dehydration is absent but still persistent diarrhea is present, treat the child. General treatment is what? When general treatment. So what is the treatment for severe dehydration? What is called diet A, diet B, diet C plan? I am expecting my kids to answer. What is called diet A, diet B, diet C plan? Often asked MCQ. Diet A, Diet B, Diet C plan in severe acute, in persistent diarrhea. Finally, one person is coming suddenly saying, "Good evening, sir." Almost we are going to say good night to you. What is diet C, Pa? What is diet C? Remember, when persistent diarrhea is present, it means that the child cannot absorb lactose. So you are reducing the lactose. Despite reducing the lactose, if the child still has diarrhea, it means that other disaccharidoses, that sucrase, maltase, are not absorbed. So you are going to remove your sucrose, maltose, etc. So what is called diet A, diet B, diet C plan? In diet A plan, low lactose diet. What is called diet A plan? Diet A plan is called low lactose diet. Low lactose diet, diet A plan. What is diet B plan? He might be thinking, why should I have said good evening to this bloody sir? Okay, he must have been thinking that. Okay, so what is that diet A and diet B and diet C plan? Diet A plan is low lactose diet. You reduce the lactose content. You give 50 ml per kg per hour. That is diet A plan. No, diet B plan is, as Lakshmi said, it is no lactose diet. No lactose diet. Whereas cereals, glucose, everything will be given. What happens in diet B plan? Diet B plan, again no lactose diet. Everything will be continued. Everything will be continued. In diet A, reduced lactose diet. Diet B, no lactose diet. What is diet C? Neither lactose, I am sorry, neither lactose nor cereals, also not given. It is mainly based on giving simple monosaccharide based diet and protein. Monosaccharide based diet. They won't give complex carbohydrate. They will give simple carbohydrates, glucose directly, along with protein is supplemented with egg and chicken. Protein is supplemented with egg and chicken. This is called diet C plan. Start with the diet A plan, reduced lactose diet. Start with the diet B plan, no lactose diet. Start with the diet C plan, no lactose, no starch diet. Neelam Bhatia, very good. Give plain glucose, egg albumin, protein. Egg albumin, protein. Protein. Now tell me, what is the only drug that you give in all cases of diarrhea? What is the only drug that you give in all cases of diarrhea? Tell me, the only drug that you give in all cases of diarrhea. I am waiting for your answer. Zinc. Why that query, my dear boss? For certain things, if someone is asking, say yes. If some girl is asking you, do you love me? Say yes, that's it. Zinc means yes, it is zinc. So zinc for about 14 days, whatever it may be. Zinc for about 14 days in all cases of diarrhea. In persistent diarrhea, along with that, you give single bolus dose of vitamin A. Single bolus dose of vitamin A. Vitamin A. Right. What is the treatment for blood in stools? Waiting for my kids to answer. What is the treatment for blood in stools? Waiting. Answer. The treatment for blood in stool. What drug you will give for blood in stools in pediatrics? As per INICET protocol. Waiting for the answer in the chat box. The answer is cefixime for 5 days. Answer is cefixime for 5 days. Metronidazole. Okay. It is not metronidazole, ma. We don't use metronidazole in pediatric age group. Please take MD General Medicine. You will be a great practitioner, I bet. Taranta Das. Cefatoxim Lakshmi Krishnan. Definitely she is going to mint a money by admitting all children with blood in stools. Okay. Answer is cefixime. Again metronidazole. It is cefixime for about 5 days. No need to admit children. The only indication for metronidazole is you don't have enough thing here, or else you will be having, okay, or else you will be having hospital to admit him for cefatoxim. Just leave it. You need a break, or shall I continue? 10 minutes break. The time is 8:50. Do you need a break, or shall I continue? I am fit enough to continue my session. And if you want to have something, you just have any food listening to our class. I don't want you to be very serious in listening my classes. Shall I continue, or you want a 10 minutes break? It was set actually at 8:30. I will wait for first 5 options. 1, continue. So it means yes means what? Neelam, you want me to continue? You have some snacks. Ask your father, mother, grandma, grandpa to get something for your snack break. Out of 5, out of 6 equal, as per protocols, I need to go for break for about 15 minutes. Let us take a break. So this is called PW. Shall we start? Have you joined? Shall we start? My dear boys and girls, are you there? If I see 3 to 5, yes, let me start. Okay. Where are my kids? Yes, healthy pill is having some healthy pills and come here. Troponin. I hope that your troponin should not rise throughout your life. Okay. Okay, let us start. Don't worry. In order to have a good flow, I have skipped 2 questions that will be discussed to have a good uniform flow. Exclusive breastfeeding includes all except. Exclusive breastfeeding includes all except. Breast milk, ORS, vitamin D drops, none of the above. The answer is left to you. Answer is B. Okay, let us clap for Taranka, Tropical, Osama. Shall I? B. Answer is B. See what a simplest question that we had given. But at times simple things are always leads to some kind of issues. Don't worry, my dear boys and girls. We will be there to take care of all those things. It is not answer. See, it is none of the above. What is this, sir? Exclusive breastfeeding means what? The definition changes, my dear boys and girls. Exclusive breastfeeding includes breast milk plus ORS plus vitamin D drops plus medications given to the mother. Plus medications given to the mother. Extremely new, na? Extremely new thing. Breast milk, exclusive breast milk includes ORS, giving vitamin D drops and giving medications. It all includes exclusive breastfeeding. Okay, right. Is it surprising to you? Is it surprising to you? If yes, okay, take surprises. Oops, yes, it is new. I could guess from the reactions given in the boxes what kind of smile you are giving. Okay, let my kids learn new things from PW team. Okay? Right. Because we have been constantly updating and we have been working in tertiary health center. Okay. Not even water. That includes not even water includes, but ORS is included. Okay. What do you mean by exclusive breastfeeding? Exclusive breastfeeding is giving breast milk along with ORS, vitamin D, medications. Medications. 1. Predominant breastfeeding means you are giving 75% breast milk, 25% others. 25% others. What do you mean by mixed feeding? Mixed feeding means 25 to 75% breast milk so that 75 to 25% other foods. Predominant artificial means less than 25% breast milk and more than 75% artificial milk. Exclusive artificial milk is no breast milk and exclusively other things. Exclusively other things. This might be new to my boys and girls, so let it be. Exclusive breastfeeding means it includes ORS, vitamin D, medications. Whereas Predominant breastfeeding means more than 75% breastfeeding, mixed between anywhere between 25 to 75. Predominant artificial is more than 75% of artificial feeds and less than 25% of breast milk. And finally, exclusive artificial means no breast milk. It is exclusively by other milks. Never heard Taranka Das. Yes, we are going to tell you some new points which you have never heard in some other things. But this is from the guidelines. It has been changing over the past years. Now, whey casein ratio in mother's milk is. Next question. So what is the answer, my dear boys and girls? I repeat, exclusive breastfeeding includes breastfeeding plus ORS plus multivitamin drops and some medications that you are giving. Whey casein ratio in mother's milk is. Now you need to compare between 60-40. Troponin, Tropicana D, Nalim C, Arunan 80-20. Okay. Let us crack this question. You have major nutrients, minor nutrients. What are all major nutrients? What are all major? Carbohydrate, fat, proteins are major nutrients. Whereas minor nutrients are vitamins, minerals and trace elements. When you come to major nutrients, one is high in human milk, one is high in cow milk, one is equal in both human and cow milk. Simple formula. One is high in human milk. What is that? Lactose. Lactose 7 grams in human milk. In cow milk it is 3 grams. Lactose is more in cow milk. Whereas fat, protein, what about protein? The protein content of human milk is 1.2 gram per liter, whereas protein content of cow milk is 3.2 gram. It is high. But remember, there are two types of proteins in milk. One is whey protein, another is casein. Whey protein is most easily digestible and less allergic, whereas casein is not easily digestible and more allergic. That's why infants who are fed on cow milk develop cow milk protein intolerance, which is mainly due to casein content of the cow milk, whereas this casein component is less in case of human milk. That's why even though the total protein content is less compared to human milk, the whey protein is 60 and casein is 40. Whereas in cow milk, whey protein is 40% and more of allergic that casein. And when you come to fat, both human milk and cow milk contains, what is that? Contains anywhere around 4 grams or 3 point, anywhere around, both contain same. Lactose, carbohydrate is more in human milk, protein is more in cow milk, fat is more in both human milk and cow milk. Remember essential fatty acids. Your essential fatty acids. What are all essential fatty acids? Your linoleic acid and linolenic acid. Your linoleic acid is omega-6 fatty acid and linolenic acid is omega-3 fatty acid are more in human milk but not in cow milk, but less in cow milk. What about calcium phosphorus ratio? Calcium phosphorus, what should be the normal calcium phosphorus ratio in children to have a good bone growth? Can anyone tell me what should be the normal calcium phosphorus ratio? The normal calcium phosphorus ratio for a healthy bone growth is 3:1 ratio. In human milk, it is 100 gram of calcium along with 90 gram of phosphorus. I am sorry. This happens in case of, I am sorry. So it is 100 gram versus per liter versus 90. What is that ratio? 1 is to ratio. This 1 is to 1 ratio of calcium phosphorus ratio will cause chelation of calcium when an infant is fed with cow milk. As a result of which, a child with when fed on cow milk can lead to late onset hypocalcemia. What is called late onset hypocalcemia? Hypocalcemia occurring more than 72 hours is called as late onset hypocalcemia because of the ratio of calcium to phosphorus 1 is to 1. Whereas calcium to phosphorus ratio in case of cow milk is exactly 3 is to 1. Is 3 is to 1. That's why human milk avoids hypocalcemia. And finally, iron is, even though less, it is easily absorbable. What are all the 2 vitamins that has to be supplemented while the child is on exclusive human milk? What vitamins should be supplemented while the child is on exclusive breastfeeding? I repeat, what 2 vitamins? I am waiting for my kids to answer. What 2 vitamins? Yes, one is vitamin K initially. That's why a newborn of more than 1000 grams, okay, not a newborn of more than 1000 grams should receive 1 milligram of vitamin K IM, and less than 1000 grams should receive 0.5 milligram of vitamin K IM, because vitamin K is mainly predominantly secreted by intestinal flora. In the initial period, the intestinal microbial flora of the infant cannot produce vitamin K. That's why all healthy breastfed infants on exclusive breast milk should be given vitamin K intramuscular 1 dose. 1 milligram more than 1000 grams baby and 0.5 milligram less than 1000 grams baby. Apart from that, as many told, vitamin D 400 international units per day. These 2 vitamins should be supplemented. Vitamins should be supplemented, and my kids have answered correctly. The answer is C, 60-40 whey casein in humans milk. I am very happy my kids have answered well. Instead of learning so many things on vitamins, let us know certain mandatory things that will be asked in your NEET or next. What are all those mandatory things? Tell me. What are all those mandatory things? Tell me. Neuroregression. Question number 17. Neuroregression with alopecia is a feature of which vitamin deficiency? I repeat, this question has been asked multiple times in INICET as well as in NEET. Why? Because it make wonders in someone's life. It is not only for entrance MCQ. I have seen a child with a developmental delay along with alopecia and dermatitis. When our professor neurologist has given this vitamin supplement, the child seizure has stopped, milestones has achieved, and hair growth had come, and my kids have answered correctly. It is biotin. It is biotin. Biotin depends on what? What is that neuroregression with alopecia? It is called multiple carboxylase deficiency. It is biotin is a cofactor for multiple carboxylase deficiency. Carboxylase deficiency. Now let us see one by one vitamin and what are all the roles of those vitamins. What is the role of thiamine? What is the use of thiamine? Can anyone tell me? Thiamine is more common in people eating what? Thiamine is more common in people eating what? Can anyone tell me? Thiamine is due to people eating dash. What it is actually? Yes, exactly. Thiamine is due to eating polished rice. Polished rice. Not only, you all know that thiamine can be used in definite suddenly going to B7, I don't know. What is the role of thiamine? Thiamine is used in the following disorders. Thiamine responsive megaloblastic anemia. This is not for NEET. This is definitely for INICET. Thiamine responsive megaloblastic anemia 1. Thiamine responsive megaloblastic anemia. Megaloblastic anemia. Thiamine is a cofactor for alpha keto acid dehydrogenase. So it is used in maple syrup urine disease. Maple syrup urine disease. Thiamine is also useful for leaks encephalopathy, which is a basal ganglia dysfunction and which is a mitochondrial disorder. Thiamine in case of leaks encephalopathy, very important. At least one question will be okay. One question will be asked in okay. One question will be asked in this section on vitamins. Okay. Section on vitamins. Thiamine is useful in thiamine responsive megaloblastic anemia, maple syrup urine disease, as well as in leaks encephalopathy. Right. Circumcorneal vascularization, where it occurs. Circumcorneal, which vitamin deficiency leads to redness around the cornea. Circumcorneal vascularization. What it is? Tell me. Circumcorneal vascularization. Waiting for my boys and girls to answer. Waiting da, we have so much to learn. Which vitamin deficiency leads to circumcorneal vascularization? No. Circumcorneal vascularization is due to dash. What it is? Riboflavin, tropocalcitonin, riboflavin. Okay. Troponin, very good ra. He is a combination of troponin and calcitonin, I think. Riboflavin. It is not Osama. It is riboflavin. Very good. Riboflavin. Neuroregression with alopecia. Just now my kids answered. It is biotin deficiency. Biotin deficiency. Neuroregression with alopecia. Pancytopenia is a feature of which vitamin deficiency? Pancytopenia is a feature of which vitamin deficiency? I repeat. Pancytopenia is a Disorder of which vitamin deficiency? Let me say B complex vitamin, one of the B complex vitamin, which is useful for DNA synthesis. This is the clue I can give to my kids. Why? What happened to all my kids? Okay. What is that? Pancytopenia. Yes. No one has answered. Who is there? Lakshay Sharma. Come on, man. Hands five. Hands five. Capricorn. Hands five. Yes. B12 deficiency. Very, very important. B12 deficiency. Again, knuckle hyperpigmentation is a feature of B12 deficiency. People have been thinking about not folate, it is B12. People have been thinking about only subacute combined degeneration of spinal cord. Subacute combined degeneration of spinal cord. Apart from that, pancytopenia, knuckle hyperpigmentation, and remember, you all know megaloblastic macrocytic anemia. Megaloblastic macrocytic anemia. B12 deficiency. Again, one more point. Is B12 deficiency is associated with neuroregression? Can anyone tell me? Is B12 deficiency is associated with some movement disorder? B12 deficiency is associated with any movement disorder? This question was asked so many times in AIMS previously. Which movement disorder is associated with the B12 deficiency? You must be knowing megaloblastic anemia, macrocytic anemia, subacute degeneration of spinal cord. Knuckle hyperpigmentation also my kids know. But what is that called as? Infantile tremor syndrome. Infantile tremor syndrome. What is that called as? Infantile tremor syndrome. Have you heard of this? But this question was asked twice in AIMS. Infantile tremor syndrome, B12 deficiency. What is the marker or screening test of choice for B12 deficiency? And again, I am waiting for the answer because there are so many questions that can be asked with respect to B12 deficiency. What is the marker or screening test for B12 deficiency? I am waiting for my kids to answer. Are you there? I am waiting for the answer. 10 seconds. Very good, Lakshay. Methyl malonic acid is converted into succinyl CoA. Succinyl CoA. Succinyl CoA by B12. So in B12 deficiency, methyl malonic acid in urine is the screening test. Lakshay, very good, my dear boy. The screening test is not Schilling test as you have read. It is methyl malonic acid levels. Methyl malonic acid levels in urine. Acid levels in urine. Is this new or old point to you, my dear boys and girls? Is it new or old point? I just wanted to know. That's it. Methyl malonic acid in urine is the screening test for B12 deficiency. I repeat. It is not your hypersegmented neutrophils. It is not your Schilling test. It is methyl malonic acid in urine. And remember, B12 can be utilized in methyl malonic aciduria. Next point. So it can be used in methyl malonic aciduria. Another inborn errors of metabolism. New point. Very good. Obviously, a teacher will be happy only when you say, yes, sir, you have taught a new point. Okay, you made my day. Thank you. Right. Mithil, but it has been there for the past 10 years, my dear boys and girls. Been there for the past 10 years. ठीक है, baby? Right. What is this? What vitamin deficiency leads to hemolysis in newborn? Any newborn with severe hemolysis. It is not a ABO incompatibility or RH incompatibility. I repeat, which vitamin deficiency is associated with hemolysis in newborn? An often asked question. Hemolysis in newborn and anemia in newborn. Vitamin K. Vitamin K excess leads to hemolysis. No, vitamin K excess leads to hemolysis. Not deficiency, pa. Vitamin K excess leads to hemolysis. Vitamin, I am not talking about G6PD. It is. I repeat, no, again a new point for my kids. Any child with preterm particularly, I repeat, listen carefully. A preterm with hemolysis, you need to suspect that antioxidant vitamin. Lakshu, very good. Antioxidant vitamin. Vitamin E deficiency. Vitamin E deficiency should be suspected in any preterm with hemolysis and also any child with unexplained ataxia. Any child with unexplained ataxia should be investigated for vitamin E deficiency. I repeat, vitamin E mainly meant for entrance MCQ, preterm hemolysis anemia, vitamin E deficiency, whereas unexplained ataxia, vitamin E deficiency. Okay, very good. Hematemesis in newborn. Now my kids will answer just like that. Hematemesis in newborn. Yes, vitamin K. Vitamin K deficiency. What is this? Hematemesis at 4 months. Hematemesis at newborn period. What is hematemesis at 4 months? Something new. Is it due to vitamin K? The answer is yes. What are all the 3 types of vitamin K deficiency bleeding? It's my responsibility to answer here. Vitamin K deficiency bleeding. Vitamin K deficiency bleeding. VKDB. Type 1 or classic, let me say. There are 3 types. Classic, late. It is called hemorrhagic disease of newborn. It is called HTN, hemorrhagic disease of newborn. Classic onset is 2 to 12 weeks. 2 days to 12 weeks. 2 days to 12 weeks. It is due to not giving vitamin K. Not giving vitamin K injection after birth. This is classical hemorrhagic disease of newborn. Whereas late onset HTN is usually classic HTN, whereas late onset HTN is anywhere between 12 weeks. Okay, anywhere between maybe little bit. So let me say a small correction, my dear friends. A small correction. Okay. 2 days to 2 weeks, whereas this is 2 weeks to usually 4 months. 4 months. And remember, 2 weeks to 4 months, it is due to malabsorption. Malabsorption. Can anyone tell me what is the condition that can lead to fat soluble vitamin malabsorption that is increasingly being recognized in our country? Fat soluble malabsorption responsible for late onset HTN that is increasingly being recognized in our country. I am asking my kids. Anyone? Bet it will be a question from your INICET. It will be a question for you in INICET. Which condition which produces fatty malabsorption increasingly recognized in our country? Previously, it was in the past 1 decade, many people have been diagnosing it. The clue was given fat soluble vitamin, steatorrhea, pneumonia. The clue was over. 1, 2, 3, 4, 5. Cystic fibrosis. What happened, Ra? Okay, no issues. New thing. Cystic fibrosis. Fatty acid malabsorption. It is not Crohn's, Taranka. It is cystic fibrosis. And finally, the third type. What is the third type? Finally, the third type. Hemorrhagic disease of newborn occur in day one due to maternal anticonvulsant which hinders with vitamin K absorption, cystic fibrosis, maternal anticonvulsant as well as maternal ATT. This is third type of HTN. Very, very important for your entrance MCQ. Classic not due to vitamin K injection, late onset due to malabsorption, third type is due to maternal anticonvulsant. Finally, what is the manifestation? Classic onset HTN can cause hematemesis. Most common presentation hematemesis, or it can cause epistaxis or umbilical bleed. But your late onset HTN entrance MCQ will present with cerebral hemorrhage and death. Cerebral hemorrhage, intracranial hemorrhage and death. This is an entrance MCQ. Even though vitamin K classic onset HTN produces hematemesis, epistaxis and umbilical bleed, your late onset HTN will lead to intracranial hemorrhage. One manifestation of cystic fibrosis is late onset HTN or intracerebral hemorrhage. Cerebral hemorrhage. Okay? Right. What is this? You have read about fat soluble vitamins, water soluble vitamins, and what is this? Spastic diplegia, which micronutrient deficiency. I am not going to say about vitamins. Trace element deficiency leads to spastic diplegia. You know, the answer is very clear. Endemic cretinism. What is the answer? Endemic cretinism. My kids will answer spastic diplegia, deaf mutism. 2 clues. Spastic diplegia along with the deaf mutism. What? Tracer deficiency, which is added in 25,000 salt. Yes, it directly goes without saying iodine. Again, myxedema. Iodine, endemic iodine deficiency can be due to either myxedematous cretinism or neurological cretinism. Myxedematous cretinism will present with myxedema, typical cretin, short, mental and physical retardation. Whereas neurological cretinism will present with, so this is myxedematous. Whereas neurological cretin will present with spastic diplegia plus deaf mutism. Is it new or old? Yes, my kids will answer. And it was a common factor by my kids say glucose intolerance. Glucose intolerance can be due to sprue. What is that? Sprue, Augustine. What is that? Milik. Okay. What is this? Glucose intolerance. It was added as a treatment along with the insulin. What is that micronutrient that was added along with the insulin so that it increases insulin sensitivity? 1, 2, 3, 4, 5. Yes, it is chromium. It is chromium. No zinc, it is chromium. Again, is it new? Okay, let it be. Life is a period of constant learning. Cardiomyopathy, again my kids will say. Cardiomyopathy, my kids will say. Cardiomyopathy, Keshan's cardiomyopathy due to selenium. What is this? Mimics myxedematus cretinism but not iodine. Now you answer. Mimics myxedematus cretinism but not iodine deficiency. But not iodine deficiency. Answer. Mimics myxedematus, very good. Tropocalcitonin, very good. I think you have been answering for cardiomyopathy or me. This is also selenium deficiency can also due to myxedematus cretinism. And finally, skin and hair changes. My kids have already answered biotin. Already answer, it is biotin. Neuroregression with skin and hair changes. Even though they are single one-liners. Always zinc, 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 zinc. Why zinc, boss? There are so many things beyond zinc. Okay? Right. Finally, hypocalcemia not responding to calcium infusion. A child is having hypocalcemic tetany. The child was given 10 ml per kg of 2 ml per kg of 10% calcium gluconate, but tetany is not responding. Then which is essential for the which trace element is essential for the action of calcium? Which trace element is essential for the action of calcium? This question has been asked thrice in NEET and INICET. Hypocalcemia not responding to calcium infusion. Waiting. Damn sure question. Damn sure question. Hypocalcemia not responding. Healthy pill, very good. Magnesium. Magnesium. And finally, chota points. The one which reduces cholesterol and increases clotting factor is dash. Little bit difficult, okay, but let me explain. It is manganese. It is manganese. Whereas one which is associated with the night blindness but not vitamin A is molybdenum. Is molybdenum. Is molybdenum. Someone is saying phosphorus. What phosphorus? Yuvraj, no, my dear boy. What is this? The one which is associated with hypogonadism, reduced cell-mediated immunity, diarrhea, acrodermatitis. Yes, my kids will answer just like that. What is the answer? Hypogonadism, reduced cell-mediated immunity and acrodermatitis. Zinc, it is easy. Okay, let it be zinc. Now spotters. Very good, ma. Leave it, ra. Spotter. What is spotter 1, spotter 2, spotter 3? All are my ward patients, our ward patients. spotter 1, spotter 2, and then spotter 3. What are all they? What are all they? Spotter 1, spotter 2, spotter 3. Answer. This is 1, 1, 2, 3. Answer, my dear boys and girls. And what is spotter 4? Cranios. We have been discussing about Arunan, spotter 4 audience. Please give a grand hand to Arunan. Spotter 4 is audience. Amazed with your answers, amazed you with your presence of mind. Amazing, Arunan. Spotter 4 is audience. Okay. Spotter 1, 2, and 3. Audience. Spotter. Okay. What is that? Sparse hair. What is that? Sparse hairs. So this is a case of biotin deficiency. Sparse hair. What is this? Which vitamin deficiency can lead to this? Which vitamin deficiency can lead to this? Spotter 1 is alopecia. Not craniostenosis. Craniosynostosis will have microcephaly. What is spotter 2? Spotter 2 is neural tube defect. It is due to folic acid. And then spotter 3. This child had come with loss of milestones. Folic acid. What is spotter 3? Spotter 3. Folic acid. What is spotter 3? Spotter 3 da. No. Hyperpigmentation. What happened to my boys and girls? Look at this. Hyperpigmented knuckles. Very good, Tushar. Hyperpigmented knuckles is a manifestation of B12. I repeat, hyperpigmented knuckles. Knuckles is a manifestation of B12 deficiency. Is a manifestation of B12 deficiency. And what is this? Audience. Okay. I am amazed with the presence of mind. Okay. It is audience. So, entrance mark will be 100 to 100 for him. For his presence of mind. Okay. Damn sure you will be asked this question. Damn sure. Okay. Right. Right. The last, okay, not last. What is this? The following are true about breast milk storage except. The following are true about breast milk storage except. Expressed breast milk can be kept for 6 hours at room temperature. Leftover milk. For example, the child is taking 50 ml, another 50 ml in bottle. Ideally, it should not be, not even bottle, whether it is a palide, feed or any feed. This leftover milk can be used within dash hours. Thawed milk. Thawed milk means what? Once it is kept in freezer, taking out, that solid has become liquefied. That is called thawed milk. Thawed milk can be kept in freezer again. Third question. And finally, expressed breast milk can be kept in freezer for 12 weeks. That is 3 months. Which one of the following is wrong? I am waiting for my kids to answer. Which one of the following is wrong? Again, I don't know whether this point will be new to my boys and girls. Let me see. PW is here to teach you new things that is going to be asked in the entrance MCQs, as well as reinforcing your old ideas to make it so clear, crisp. Answer. I am waiting for my kids to answer. Which one of the following is false about breast milk storage? Taking such a long time, let me proceed. Expressed milk can be kept in room temperature for 6 hours. Very, very important. Can be kept in room temperature for 6 hours. Can be kept in freezer 2 to 8 degrees Celsius for 1 day. Can be kept in freezer for about, is it new, my dear boys and girls? Why you are not answering? Or is it a lag between my relay and your YouTube watching time? 2 hours. Freezer for about 3 months. This all my kids know. I am sure. Leftover milk, you take 50 ml, another 50 ml is kept. This must be new to my kids. It is 2 hours. Leftover milk can be taken within 2 hours. After that, discard. Discard. Thawed milk. Thawed milk means you kept in freezer. You take it, allow it to go for room temperature, and then when you are going to take, can it be kept in room temperature? Yes, 1 hour. Can be kept in freezer? Yes, 1 day only. 1 day only. But remember, my dear friends, a thawed milk, frozen milk, again you are taking out liquid, it becomes liquid. Again, please do not keep in freezer. So it is not allowed. I repeat, it is not allowed. A thawed milk should never be refrozen because it will become angiotoxic because oxidation of the cholesterol in the milk. It is angiotoxic. Is it new, my dear boys and girls, for you, or it is taught by someone? Both of it is okay for me. If it is new, PW will be happy. If it is old, we will be happy to reinforce the point. Answer. Okay, interact, boss. Are you feeling drowsy? You had something. Again, when you have something, if you have something, particularly protein rich foods, protein contains what? Serotonin. Serotonin will be converted to tryptophan. Tryptophan will be converted into melatonin, and melatonin goes and acts on the circadian rhythm to develop sleep. That's why when you have so much of protein rich foods, the melatonin conversion from the serotonin and tryptophan leads to sleepiness. Okay? Don't take more amount of food before your class. And if you want to take if you want to sleep, particularly for someone, take something, take protein for rich food and sleep. Next point. What is this technique called as? What is this technique called as? 1, 2, 3, 4, 5. What is this technique called as? This technique is meant for relactation. This technique is meant for inverted nipples. This technique is to avoid breast confusion, and this technique is employed to prevent breast engorgement. What is this technique called as? Kangaroo mother care. It is not kangaroo mother care. For breast confusion, even carb-rich foods can cause sleep. That you know why carbohydrate-rich foods cause sleep, Yuvraj? More and more good carbohydrate, this amount you eat, what will happen? It will lead to diversion reflex, so that the blood from the brain will be diverted to intestine and stomach. That's why you get sleep, because of carbohydrate food. No one has answered. Even I am expecting my girls, future mothers, to answer this question. What is this technique called as? No one has answered, including my future mothers. This is called as supplementary. This is called as supplementary suckling technique. Have you heard of this, my dear boys and girls? Supplementary suckling technique. What is this? When a mother becomes sick due to some illness, and the mother is getting admitted, so that the child is away from the mother. When the child's mouth cannot suck the breast, automatically prolactin secretion will be stopped, and the mother will stop secreting milk. After 1 month, the mother is discharged from hospital, and the mother wants to give breast milk. How it can be attained? 1 month, no milk. Suddenly, how the child will get milk? When the child starts sucking, no milk is going to come, and the child will be irritable. In that instant, what you need to know? The continuous suckling will improve prolactin secretion and relactation, but the child should suck something from the breast, but here breast is empty. So that what you need to do, take a formula fits or animal milk in a cup. One end of the NG tube is immersed in the cup with artificial feeds or formula milk or animal milk. The other end will be attached to the nipple. So that what happens? When the baby suck from the nipple as well as from the breast, it will automatically get the milk from the cup that is kept near the breast, and also it will continually stimulate the nipple, leading to relactation. Have you heard of this, my dear boys and girls? This is called relactation or supplementary suckling technique. Okay? This is called relactation or supplementary suckling technique. It is not for all these stupid things. This was once asked in Jipmer. Not necessarily that. Whenever you face this kind of situation in future, for you it should not happen. Or if someone wants to give relactation, some mother are so particular in giving relactation, try this technique of supplementary suckling technique. It will produce a very good result. Is it new to my boys and girls? Is it new to you? Supplementary suckling technique. Okay, next question. Okay. Shall I go for the next question? Let us go. So, mission accomplished. Right, let us go. A young mother known to be infected with HIV but not on ART treatment reports to the pediatric department with her 1-week-old infant with an unknown HIV status. Mother is HIV positive, not on ART treatment, and she brought her 1-week-old child with unknown HIV status. With unknown HIV status. You have not checked the HIV status of the baby. I am not going to speak about how to find out HIV in a baby. Leave it. Unknown status. But she wants to give breastfeed. The following are true except. What is the management? Start ART to the mother. Say yes or no. Nevirapine should be given to the baby for 6 weeks. Nevirapine for the infant up to 12 weeks. Breastfeeding continued till 12th month. Abrupt cessation of breastfeeding and replaced with complementary feeding. The following are true except a majority have or of you have answered I am happy except 2 things. HIV and breastfeeding. HIV and if the mother had took treatment, we could have given nevirapine up to 6 weeks with breastfeeding, but female did not take therapy. Yanda, why man, why? Don't create any confusion. Leave it. HIV and breastfeeding. I am sorry for using HIV and breastfeeding. Start ART for all mothers irrespective of stage of HIV or irrespective of CD4 content. 1. Start nevirapine prophylaxis. If the mother took more than 24 weeks of ART, then 6 weeks of nevirapine is enough. If the mother took less than 24 weeks during pregnancy, then you need to give 12 weeks of nevirapine. You need to give 12 weeks of nevirapine. Again, that abrupt cessation of breastfeeding and starting weaning is no more practiced right now, because it was initially thought that when you start weaning, the large protein molecule present in the supplementary feeds will cause injury to the intestinal epithelium of the infant. Through that, the whatever HIV organisms that is present in the breast milk will enter. But right now, this theory has become an old one. And what is the new thing? You give exclusive breastfeeding for 6 weeks. Start complementary feeding along with breast milk at 6 weeks, along with breast milk, because it is the protection that is going to be given by the breast milk rather than the meager amount of HIV that is present in it. And finally, exclusive breast milk 6 weeks, and finally breast milk can be continued to 12 months, if possible 1 year. Sorry, if possible 2 years. If possible 2 years. Possible 2 years. So what is the treatment? Start ART to the mother? Yes. Nevirapine for infant up to 6 weeks. Remember, here the mother is not on ART. So it is not 6 weeks, it is 12 weeks. Breastfeeding to be continued till 12 months? Yes. Here the mother did not take ART. Neelam, that's why the child has to be on nevirapine for 12 weeks. Abrupt cessation. Is it clear, my dear boys and girls? Both B and E. B is correct, provided if the mother took ART during pregnancy for more than 24 weeks. Here the mother not on ART. That's why, even though it looks correct, it doesn't fit into this scenario. Okay. Okay, baby, a little bit of confusion to make things clear. Okay, right. Shall I go for the next question? Sir, mother doesn't want to. This question an extension. Mother doesn't want to give breast milk. Then what should I do regarding replacement feeds? Make sure whether the mother can afford, whether replacement feeds are feasible, whether mother can offer. This is called AFAS. Whether it is acceptable to the baby. You want to give some replacement feeds that should satisfy these things. It should be affordable, it should be acceptable, it should be feasible, and it should be safe, and you need to give sustained. This is called AFAS criteria. So what is AFAS criteria? AFAS criteria is whenever mother wants to give lactation, mother wants to give replacement feeds, it should be A for affordable, F for feasible, A for acceptable, S for sustainable, and S for safe. When this is possible, then you can go for replacement feeds. Otherwise, do not go for replacement feeds. Okay? Otherwise, do not go for replacement feeds. Right. Do not go for replacement feeds. The next question. Rickets. You will be getting rickets in pathology, physiology, pediatrics, medicine, everything. Now we are going to delineate or decode the physiology, the treatment, as well as the approach to rickets. Are you ready, my dear boys and girls? Let us try our knowledge with this case scenario. A 7-month-old child presents to the OPD with classical, clinical, and radiological features of rickets. The infant had alopecia and epidermal cyst. Her calcium phosphorus ratio is low. Levels of vitamin 25D is normal, whereas 125 is extremely elevated. What is the treatment? Here the question is what is the treatment, but my question is what is the diagnosis of this rickets? Then you go for the treatment. And this is our ward patient. What are all the features in this ward patient? What is this? What are all the things you can get? You all know what are all the findings? The findings that you know are my kids know frontal bossing. My kids know about frontal bossing. Craniotapes, that is soft nature of calvaria. Craniotapes, otherwise known as ping pong feel. Ping pong ball feel, that is very soft. Wide AF and wide anterior fontanelle. Wide anterior fontanelle. Severe, I am coming from top to bottom. Severe dental caries or delayed dentition. Severe dental caries or delayed dentition. Again, what is this? Look here. Rachitic rosary. Painless bending of Postchondral junction, that is called rachitic rosary. Because of the absence of vitamin D, calcium, the tone of the abdomen is poor. You will get pot belly. You get pot belly. And here there is one thing. Here there is one thing. What is this? This is called this is called varus deformity, and this is valgus deformity. Valgus going out. This valgus deformity leads to knock knee. This varus deformity leads to bow legs. Sir, I could find both varus and valgus in the same limb. Have you ever seen this? This combination of varus in one limb and valgum in another limb is called because it is wind swept deformity. Very good. Wind swept deformity. Wind swept deformity. Again, these things are very well known findings. That is known to my kids. What are all the X-ray features? This is my clinic's case. Post COVID, we have been seeing plenty of cases of rickets because majority of them are at home, not exposing their children to sunlight, leading to nutritional rickets or vitamin D deficiency rickets. What is this? Widening of epiphysis. Widening. Here I don't find cupping, but there will be cupping. In my clinic, cupping has not developed. Cupping. And then there is serrated border of the end of epiphysis. This is called fraying. So widening, cupping, fraying, and then generalized rarefaction or osteoporosis. Generalized rarefaction or osteoporosis. I repeat, my kids who are listening this particular segment is not going to mug up things regarding X-ray, not going to mug up things regarding rickets. Let us crack the basic behind the rickets. Let us crack. Should I go for a 3 minutes physiology and 3 minutes pathology we have discussed? A 3 minutes physiology to make you understand rather than simply mugging up your theory. If it is so, I will proceed with the 3 minute simple physiology. Yes, no. I'll be waiting. There are many people at home for you to give something, but at present I am alone in my studio. Okay, not even water. Okay, let's see. Shall I go for it? Sir, please. Yes, sir. Healthy pill, go. Okay, done. Yes. What happens? Ultraviolet B of sunlight falls on 7-dehydrocholesterol in order to produce cholecalciferol. Vitamin D2. This cholecalciferol goes to liver where it is converted into 25-OH-D3. Then this 25-OH-D3 will go to the kidney where it becomes 125-dihydroxy-D3. This is the storage form This is the active form. Active form. And this act on the receptors at kidney as well as intestine to absorb your calcium as well as phosphorus. Absorbs calcium as well as phosphorus. What is the storage form? 25OH-D3. What is the active form? 125 dihydroxy D3. It should act on the receptor. Now what will happen when there is vitamin D is low? Your calcium will be low because it absorbs both calcium and phosphorus. Your phosphorus absorption will be low. As a result of which, hypocalcemia and hypophosphatemia. Hypophosphatemia. This hypocalcemia but not phosphatemia stimulates parathyroid hormone, which in turn causes bone resorption, that is, erodes the calcium from the bone, leading to normocalcemia. What does it mean? In nutritional rickets or vitamin D deficiency rickets, remember my dear kids, your calcium can be normal. But what will happen? Your parathyroid causes excretion of phosphorus, leading to worsening of phosphorus. So in all cases of vitamin D related rickets, I repeat my dear friends, in all cases of vitamin D related rickets, the following things are mandatory. Calcium normal or low. I repeat, calcium can be normal in a case of rickets because of the secondary hyperparathyroidism. Phosphorus always will be low. Because of the bone turnover, your alkaline phosphate will always be high. Calcium, phosphorus, and finally, because of low calcium, there will be secondary hyperparathyroidism. When I have this constellation of low calcium or normal calcium with low phosphorus, with elevated parathyroid gland and with the elevated parathyroid gland, okay, it leads to, I repeat, vitamin D related rickets. It can be of three types. Nutritional rickets, when you have constellation of this findings, constellation of this findings, it leads to three things. Either it can be nutritional rickets or vitamin D dependent rickets type 1 or vitamin D dependent rickets type 2. How to differentiate between vitamin D dependent rickets or nutritional rickets or VDDR type 2? In nutritional rickets, what will happen in nutritional rickets? Your storage form is low. What is the storage form? Tell me, what is the storage form? Very good. Your 25OH-D3 will be low. So what is the marker for nutritional rickets? Low 25-hydroxy-D3 vitamin. It means less than 10 nanogram per ml is called deficient, whereas 10 to 20 nanogram per ml is called insufficient. Now what is VDDR type 1 and 2? Very simple, boss. VDDR type 1 is due to absence of 1 alpha hydroxylase. Absence of 1 alpha hydroxylase. Now tell me, what is the role of 1 alpha hydroxylase? It converts 25 hydroxy D3 into 125 dihydroxy D3. So what happens if 1 alpha hydroxylase is absent? What will happen to 125 dihydroxy D3? Yes, 125 dihydroxy D3 will be very, very low. So when you have a constellation of hypophosphatemia, with the hyperparathyroidism, if you have low 25 OH-D3, it is nutritional rickets. When you have a low 125 dihydroxy D3, it is called VDDR type 1. And finally, what is VDDR type 2? Your 125 dihydroxy D3 should act on the receptors. When receptors are deficient, your 125 dihydroxy D3 will be high. So VDDR type 2, it is due to end organ resistance. Leading to what? Increased 125 dihydroxy D3. Here again, let us D3. Again, making it very, 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 very simple. I will suspect vitamin D related rickets. I repeat, vitamin D related rickets when I have a combination of hypophosphatemia and hyperparathyroidism. When I have this, I will see only two things. When 25 OH-D3 is low, my diagnosis is nutritional rickets. When my 125 dihydroxy D3 is low, my diagnosis is type 1 vitamin D dependent rickets. And finally, when my 125 dihydroxy D3 is high, my diagnosis is VDDR type 2. Is it easy right now or not? We have just decoded. I don't know how many of you have utilized this simple way. If it is known, well and good. If it is not, you can learn right now. Very, very, very simple. Remember, you need to know when there is a combination of low phosphorus and high PTH. Apply this one. Easy, Capricorn. This is vitamin D related rickets. Now, sir, I have rickets. Sir, what is the treatment for this? Let me say. 25 hydroxy D3 treatment, nutritional rickets. What is the treatment? Let me say. Nutritional rickets. So, nutritional rickets. What is the treatment? Can anyone tell me? Do not say STAS therapy. Old one is called STAS therapy, in which you use 6 lakh international units of vitamin D. It is prone for hypercalcemia, nephrocalcinosis, which we are not following now. Not followed now, I repeat. What is the thing that we follow? We follow daily vitamin D oral calciferol, oral vitamin D3 daily into 2 months. That's all. How much? Less than 2 years 2000 international units, 2 years to 12 years 4000 international units, and more than 12 years 6000 international units into okay into 12 weeks, basically into 2 months. I told you it is 12 weeks, and at the end of 4 weeks, look for dash. Anyone tell me what is the response to vitamin D therapy? What is the response to vitamin D therapy at the end of 4 weeks? You take an X-ray to confirm the rickets. At the end of 4 weeks, after giving daily vitamin D2, you take an X-ray. That X-ray is going to show you dash. What is that X-ray going to show? That X-ray is going to show this one. What is this one? This was taken again in my clinic at the end of 4 weeks after vitamin D therapy. After vitamin D therapy at the end of 4 weeks. What you have seen in this X-ray? What you have seen in this X-ray? Less widening. Okay. Well, appreciable. Good, you have appreciated that. Apart from that, taken in my clinic. Most famous MCQ. Less osteoporosis. Accepted. Less widening, less osteoporosis. Epiphyseal, less widening. Accepted. But, my dear students, look at this, more whitening at the epiphysis. This is called as zone of provisional calcification. This is called as zone of provisional calcification. Do you see, do you identify in this X-ray? It is not epiphyseal thickening, my dear Yuvaraj. It is calcification of the epiphysis, otherwise called as zone of provisional calcification. This is the response to therapy. It must be known, my dear. Pause. This is the response to therapy. If there is no zone of calcification, then I will check for 125 OHD3 low or 125 OHD3 high. Low means VDDR type 1. Low means VDDR type 1. What is the treatment? Simple. You give calcitriol, that is, you give 125 dihydroxy D3. In nutritional rickets, you give 25 hydroxy D3, which is getting converted into active form. Here, active form is not present because 1-alpha hydroxylase is not present. So, here you give calcitriol plus calcium. The treatment for vitamin VDDR type 1, whereas in treatment for VDDR type 2, it is end organ resistance. You can't manage boss. It is end organ resistance. It is end organ resistance. You need to give extremely high doses of calcitriol. Despite this, the child will not respond. Despite this, the child will not respond, my dear boys and girls. That's it. This is vitamin D related rickets. Let us go to the question again. Now tell me what is the answer. For our question. Very good. Extremely high doses of calcitriol and calcium. Instead of all this, one clue. All VDDR type 2 are associated with alopecia. Entrance MCQ. Rickets plus alopecia is VDDR type 2. Type 2. Finally, one more thing is called as what? Let me. Okay. Now I am going to put one case scenario where my students are going to crack the last one, the fourth one. I have a case of rickets in which calcium is normal, phosphorus is low, parathyroid hormone is normal, alkaline phosphate is high. What is this rickets called as? What is this rickets called as? Calcium low, phosphorus low, calcium normal, phosphorus low, parathyroid hormone normal, but alkaline phosphate is high. What is the answer? What is this called as? What is this called as? Because instead of mugging up certain things, having so many facts inside, just apply the simple physiology, the beauty of physiology. Very good. Tushar Bansal, hypophosphatemic rickets. Very good. This is X-linked hypophosphatemic rickets. Phosphatomic rickets. What is the clue? Sir, there also phosphorus is low. Here also phosphorus is low. There parathyroid hormone is high. Here parathyroid hormone is normal. That is the clue. Remember, hypocalcemia stimulates the parathyroid gland, whereas hypophosphatemia do not stimulate the parathyroid gland. That's why in hypophosphatemia, your parathyroid gland is not bothered about the low phosphorus, leading to normal parathyroid hormone. Remember, my dear boys and girls, whenever you have a combination of hypophosphatemia and hyperparathyroidism, it is vitamin D related rickets. But whenever you have a combination of hypophosphatemia with the normal parathyroid gland, it is hypophosphatemic rickets. Rickets. What is the thing that is so different from other rickets? It predominantly involves lower limbs. Here there is no tetany at all. Here there is no tetany at all. Tetany at all. That's it. This is hypophosphatemic rickets. And finally, my dear friends, is it okay? Is it easy for my boys and girls? Okay. So what does it mean? It is not only calcium, not only phosphorus. Even when you have low calcium, you will get rickets. Even when you have low phosphorus, you will get rickets. Even when you have altered calcium phosphorus ratio in the form of elevated phosphorus, you can get rickets. This hyperphosphatemic rickets occurs in chronic renal failure, or parathyroid is the one which absorbs calcium and excretes phosphorus. So in hypoparathyroidism, you will get high phosphorus. These two conditions are associated with the high phosphorus. Combining all, my dear kids, look at me. Combining all, the approach to rickets will be as follows. Approach to rickets as follows. When I have rickets, the first thing I will look for phosphorus. Are you following me? Are you following me? Thank you, Ajit Sheth. Thank you. When you have phosphorus, always start with phosphorus in any case of liquor, not calcium. Da. not calcium. Always any case of ricket should be followed with phosphorus. You have high phosphorus. High phosphorus means just now I told my kids it can be chronic renal failure or it can be low parathyroid hormone. Tigeda 1. If it is low phosphorus, my kids will see pH. Sir, why suddenly you are saying pH? That we will discuss in our topic on renal tubular acidosis, because in proximal RTA you lose phosphorus, that is your Fanconi's, whereas in distal RTA you lose calcium as well as phosphorus. Always in case of low phosphorus, you need to rule out low phosphorus. You need to rule out renal tubular acidosis. Now if pH is normal, my kids will look parathyroid hormone. If parathyroid hormone is high, now my kids know in the presence of hypophosphatemia and a normal parathyroid gland, my kids will do two things, I bet. One is reduced 25-OH-D3. What is this? Very good, nutritional rickets. Another is, yes, repeat with me. Another is reduced 1,25-OH-D3, that is PDDR1. Another is 3, increased 1,25-OH-D3, PDDR2. When my kids see a low phosphorus with normal parathyroid gland, definitely my boys and girls will say it is hypophosphatemic rickets. I hope my kids will apply concepts right now rather than applying simple facts embedded in your hippocampus. Do you, my dear boys and girls, have we really decoded the concept of rickets in pediatric age group? I really wanted to ask you, have we really cracked or decoded the concept of approach to rickets? Just, okay, done. Is it easy right now, Nikhil? Okay? Shall we go for the next one? Is it easy right now? I repeat, whenever I see a case of rickets, I will just look into the phosphorus. If phosphorus is high, chronic renal failure or hypoparathyroidism. If phosphorus is low, then I will look for pH. If pH is low, proximal and distal renal tubular acidosis. If pH is normal, I will look for parathyroid hormone. If parathyroid hormone is high, if it is associated with low 25-OH-D3, nutritional rickets, low 125-dihydroxy-D3, VDDR type 1, high 125-dihydroxy-D3, VDDR type 2. And finally, when your low phosphorus is associated with the normal parathyroid gland, the diagnosis is hypophosphatemic rickets. Okay? Right. It is decoded, accepted. Thank you. Let's go to the next topic. I will be happy not with this if my kids able to crack an answer based on this pediatric PW session. Not only pediatric session, all my friends session. Thank you. Thanks for listening and thanks for staying together. Right? ठीक है? Is it okay, my dear boys and girls? Is it okay? What is it? 10:42. Okay, it is 10:42. Okay, let it be. The last thing I want to clear is congenital adrenal hyperplasia. Definitely you will get a question from this. If you are happy with continuing, let me start. Otherwise, let me plan for one more session. Shall I finish congenital adrenal hyperplasia right now, or shall we start later? It is 10:45 right now, almost 4 hours. Yes, sir. Okay. Finish, sir. Okay, finish means finish with the rickets or finish with the congenital adrenal hyperplasia. Congenital adrenal hyperplasia, let's finish. Okay, I don't know what I am going to get when I enter my house. Continue. You will say continue, but already there are so many missed calls from my wife. Let us continue. Okay, right. Again, I want my kids to know the basics. What is congenital adrenal hyperplasia? Very, very simple. Very, very simple. Shall I start? What is the time right now? 10:43. Let me start. She must be watching this YouTube channel, so not a problem right now. What is congenital adrenal hyperplasia? 1. Before going to the topic per se, you need to know the basics regarding sexual differentiation. Please do not use that word pseudo-hermaphrodite. Please, my dear Arunan, please do not use the word pseudo-hermaphrodite. That is somewhat a taboo word. Use disorders of sexual differentiation. Use ambiguous genitalia. Not even ambiguous genitalia. People are started using disorders of sexual differentiation. Okay? Right. First one is gonadal sex. First one is gonadal sex. You have an undifferentiated gonad which, when acted by sex determining region of Y chromosome, leads to testis. This testis will have your Sertoli cells and Leydig cells. Your Sertoli cells produces Mullerian inhibiting substance and Leydig cells produces testosterone. This is how gonadal sex is formed. Gonadal sex is due to sex determining region of Y chromosome sent by the male in his spermatozoa. Gonadal sex, and then you have your internal genitalia. Internal genitalia, you have Wolffian duct, and you have Wolffian duct, and you have Mullerian duct. Red is Wolffian duct. What will happen? This Mullerian inhibiting substance will act on the Mullerian duct and cause regression. Whereas your testosterone will act on the Wolffian duct and converts this into what are all the things? Converts this into vas deferens, seminal vesicle. And then you have a gonadal sex, you have internal genitalia, and then you have external genitalia. The third one is external genitalia. For both boys and girls, external genitalia are one and the same. You have a genital tubercle, you have a labioscrotal swelling, and you have a urethral fold. When you have a Leydig cell, Leydig cell which produces testosterone, it will be converted into dihydrotestosterone, which acts on the genital tubercle to make it as penis, which act on the urethral fold to make it as carpus, and labioscrotal swelling becomes scrotum. Scrotum. You catch my point? Scrotum. But when this sex determining region of Y chromosome is absent, sex determining of Y chromosome is absent. So what will happen? The gonad will become ovary. What does it mean? Female sex is the default process of sexual differentiation. When nothing happens, the undifferentiated gonad will become ovary. Now, what happens? There are no Mullerian inhibiting substance, as a result of which your Mullerian duct, your Mullerian duct will be converted to fallopian tube, uterus, upper 2/3 of vagina and cervix. And absence of what happens? Absence of testosterone leads to regression of Wolffian duct. Again, there are no testosterone, so no dihydrotestosterone. So what happens? This absence leads to genital tubercle to become clitoris. This urethral fold will become labia minora, and this labioscrotal swelling will become labia majora. That's it. Is it okay for you, my dear boys and girls? This is the simple physiology of sexual differentiation. Can I proceed to the next? Now, this is sexual differentiation that you need to know. Then we will switch to our topic on adrenal biosynthetic pathway, so that you can understand why ambiguous genitalia in female, why ambiguous genitalia in males, etc. Can I switch to adrenal biosynthetic pathway right now? I need to. Okay. Okay. Oh, we have finished so much, huh? Where is, yeah, beautiful one that I loved it. I love this chart. Okay. Okay, baby, shall we start, my dear boys and girls? This is adrenal biosynthetic pathway. This happens in adrenal gland. Look here. Cholesterol, do not get confused. Let us make it very easy. This is cholesterol. Cholesterol goes inside the mitochondria with the help of STAR. This is called steroidal acute regulatory protein. And when it goes inside, this pregnenolone is converted into progesterone with the help of 3 beta HST. Do not mug up right now. Just analysis. Just we are going to analyze the chart and how each and every enzyme deficiency is going to make such kind of devastating effect in the external genitalia. This is 3 beta HST. It is converted into pregnenolone. Just leave it. Just have a pictorial memory. Pregnenolone is converted by 21 alpha hydroxylase into deoxycorticosterone. This is converted by 11 beta hydroxylase, and finally it is converted by aldosterone synthetase in zona glomerulosa. This happens in zona glomerulosa. Zona glomerulosa. Am I clear, my dear boys and girls? What is the role of aldosterone? You need to know to understand the physiology. What is the role of aldosterone? 1 second. Aldosterone causes sodium to go inside the body, water to go inside the body, and it will cause potassium to go out, and it cause H plus to go out. So what will happen when there is low aldosterone? What happens when there is low aldosterone? Hydrogen retains. So you will get metabolic acidosis. Potassium retain. So you will get hyperkalemia. Water doesn't absorb. So hypotension. And hyponatremia. Hyperkalemic metabolic acidosis with the hypernatremia and hypotension is nothing but due to low aldosterone. Nothing else in the body can cause this physiology. Okay? When aldosterone is high, what will happen? When aldosterone is high, potassium we will lose, hydrogen we will lose, sodium we will gain, water we will gain. This leads to hypertension. This leads to hypokalemic metabolic alkalosis. Hypokalemic metabolic alkalosis. Students, very, very simple. Hyperaldosteronism leads to hypokalemic metabolic alkalosis, and hypoaldosteronism leads to hyperkalemic metabolic alkalosis. This you need to know. Need to know. Now, okay. This happens in zona glomerulosa. Okay? Zona glomerulosa. Right, don't worry, it will be easy. It will be easy only. Zona glomerulosa. Then, what happens in case of zona fasciculata? What happens in case of zona? This happens in zona glomerulosa, mineralocorticoid. What happens in zona fasciculata? In zona fasciculata, the same enzyme, that is 17 alpha hydroxylase, 3 beta HST, 21 alpha hydroxylase, 11 beta hydroxylase. But here, what is formed? Cortisol. What is formed? Cortisol. Do I need to remember? You need to remember only two things. 21 alpha hydroxylase and 11 beta hydroxylase are helpful in the formation of aldosterone and cortisol. This is what my kids needs to know. I repeat, 21 alpha hydroxylase and 11 beta hydroxylase are associated with cortisol as well as aldosterone production. Okay. As if a saint, Mary, I am explaining everything. Okay. Oh God. Right, again, then okay, then okay, then what else you need to know? This is okay. Then what happens? Now the problem stops. Whenever there is a problem in 21 alpha hydroxylase, or whenever a problem in 11 beta hydroxylase, I repeat, whenever there is a problem in 21 alpha hydroxylase or 11 beta hydroxylase, what will happen? Aldosterone will not be formed, cortisol will not be formed. In 21 alpha hydroxylase and 11 beta hydroxylase, cortisol is not formed. What happens in the fetal body? Cortisol will be low. In the fetal body, cortisol will be low. Fetal body, cortisol will be low. If cortisol is low, what will happen? The fetal pituitary will produce more ACTH. Am I correct? The fetal pituitary will produce more ACTH. What will happen? This produces more ACTH. Again, when there is 21 alpha hydroxylase deficiency or when there is 11 beta hydroxylase deficiency, your precursors pregnenolone and progesterone or hydroxypregnenolone and hydroxyprogesterone are formed. This unused precursors will be diverted into zona reticularis. Will be diverted into zona reticularis, where all of them will be converted to testosterone. All of them will be converted into testosterone. I repeat, in 21 alpha hydroxylase and 11 beta hydroxylase. Let me directly go again. Have a pictorial memory, my dear boys and girls. Have a pictorial memory. In 21 alpha hydroxylase and 11 beta hydroxylase, aldosterone will be low, cortisol will be low. Where in 21 alpha hydroxylase and 11 beta hydroxylase, and all these precursors will be diverted to the formation of testosterone. If it is a boy, this excess testosterone, that is developing fetus, excess testosterone acts on the boy to produce large penis. Or else I can say precocious puberty. Precocious puberty. If it is a girl, what will happen? This testosterone, as we explained already in our topic on differentiation of external genitalia, will cause fusion of labia, urethral fold, will cause fusion of labia scrota, will cause clitoromegaly. So, leading to ambiguous genitalia. You catch my point right now? Leading to ambiguous genitalia. So, both in 21 alpha hydroxylase and 11 beta hydroxylase, you will get increased testosterone, which produces precocious puberty in boys and ambiguous genitalia in girls. You catch my point right now? 21 alpha hydroxylase and 11 beta hydroxylase are associated with ambiguous genitalia in girls and precocious puberty in boys. Okay? Yes. Sir, is it possible to differentiate between these two things? Very, very simple. Going back to that beautiful steroidal biosynthetic pathway. Okay, let me explain one more beautiful thing. In 21 alpha hydroxylase, both deoxycortisone and cortisone and aldosterone is not formed. So it leads to hypotension. But in 11 beta hydroxylase deficiency, I repeat, in 11 beta hydroxylase deficiency, what is the precursor that is formed? The precursor that is formed is deoxycortisone. The precursor that is formed is deoxycortisone. This deoxycortisone has got equal potency like aldosterone. This deoxycortisone has got equal potency compared to your aldosterone. Equal potency compared to your aldosterone. So what happens here? This deoxycortisone will act like a aldosterone. What is the role of aldosterone? Aldosterone absorbs where it was written. Okay. What happens in 11 beta hydroxylase? In 11 beta hydroxylase, aldosterone will be high. It is not aldosterone, it is deoxycorticosterone, not drug of choice. Deoxycorticosterone will act like aldosterone, so it absorbs sodium, absorbs water, leading to hypertension. Tension. Whereas in 21 alpha hydroxylase deficiency, even this deoxycortisone is not formed, so they lose sodium, they lose water, so the presentation is hypotension. That's it. The presentation is hypotension. Now let us make it very, very simple. Now let us take very, very simple. In 21 alpha hydroxylase and 11 beta hydroxylase deficiency, in boys, in girls. In boys, precocious puberty. In girls, ambiguous genitalia. Whereas 21 alpha hydroxylase is associated with the hypotension in both boys and girls, whereas it is associated with the hypertension because of excess deoxycorticosterone. That's it. Is it clear right now? It is associated with hypotension, and your 11 beta hydroxylase is associated with hypertension. Precocious puberty with hypotension, 21 alpha hydroxylase. Ambiguous genitalia with hypertension in females, hypotension, 21 alpha hydroxylase. Whereas precocious puberty with hypertension, 11 beta hydroxylase. Ambiguous genitalia in a female with hypertension, 11 beta hydroxylase. Is it easy right now? Just simple physiology. Finally, again coming to this beautiful thing, the last but not least is this pathway. What is this pathway? 1 second. We have discussed about this 21 alpha hydroxylase and 11 beta hydroxylase, but what will happen when this pathway involves? We have discussed about the pathway involving 21 alpha hydroxylase. How many times I have been saying na, and 11 beta hydroxylase. Now let us see here if it is affected, okay. But when it is affected, this pathway, whether it is 17 alpha hydroxylase or 1720 lyase or 3 beta hydroxysteroid dehydrogenase, this horizontal pathway 17 alpha hydroxylase, 1720 lyase, 3 beta HST deficiency or 17 hydroxysteroid dehydrogenase deficiency, all these pathway will culminate in testosterone. So in 17 alpha hydroxylase, 1720 lyase, 3 beta HST, 17 beta HST, who will develop ambiguous genitalia? Is it boy or girl? Because this is reduced testosterone. So what will happen? Will it cause ambiguous genitalia in a boy or will it cause ambiguous genitalia in a girl? I am letting it to you. In 17 alpha hydroxylase, 1720 lyase deficiency. Who will get ambiguous genitalia? Are you there or went for sleep? Boy, boy, boy. Very good. So what will happen here? Ambiguous genitalia in a boy. Ambiguous genitalia in a boy, because testosterone is not formed, it is under virilized boy. Your scrotum will not fuse, your genital tubercle will not become penis, so you'll get ambiguous genitalia in a boy. What will happen to BP in case of 17 alpha hydroxylase and 1720 lyase? These unused precursors will be converted into aldosterone. So what will happen to the BP? Come on, tell me. What will happen to the BP? What will happen to the BP? Very, very simple. In 17 alpha hydroxylase and 1720 lyase, what will happen to the BP? Aldosterone is high. Sodium absorption will be high. Water absorption will be high. So what will happen to the BP? It will lead to hypertension. Very good. It will lead to hypertension. Lead to hypertension. Now, it will lead to hypertension. Finally, when there is excess ACTH, what will happen to the, when there is excess ACTH, what will happen to the when there is excess ACTH, what will happen to the newborn baby? ACTH will act on the melanosomes, which in turn causes hyperpigmented skin. Now, when you see a child who is black in color compared to the father, black in color compared to the mother, do not suspect the fidelity, boss. Do not suspect the fidelity. Don't suspect them. It can be due to a child having congenital adrenal hyperplasia. Why this is called congenital adrenal hyperplasia? Whenever you have a defect in the secretion of these end products, secondary increase of fetal pituitary ACTH, which in turn acts on the fetal adrenal gland to produce congenital adrenal hyperplasia. So when I should suspect, finally carry home message for my kids, when I should suspect this congenital adrenal hyperplasia, whenever I see a child with ambiguous genitalia at birth, ambiguous genitalia at birth, it can be a boy. Please listen to me carefully. It can be a boy or it can be a girl. If it is a boy and if BP is high, I repeat, 17 alpha hydroxylase and 1720 lyase deficiency. That's it, very clear. If it is a girl, then if you suspect ambiguous genitalia, I will divide into two. He can have low BP, the child can have high BP. As you exactly told, low BP means 21 alpha hydroxylase deficiency, whereas high BP means 11 beta hydroxylase deficiency. Cool. Suspect any child with ambiguous genitalia. Suspect any child with shock after birth, immediately after birth. Suspect any child with a hypertension to have congenital adrenal hyperplasia. Cool. At birth, the manifestations are, as I told, a black colored baby compared to father and mother. 2. Shock. A boy can present with the shock because boy usually have a normal puberty. Boy will have a normal genitalia. So you can't identify any male child who is brought with shock on the second week of birth is congenital adrenal hyperplasia unless otherwise proved. Any child with shock, any boy with the shock brought on the second week after birth unless otherwise proved, it is congenital adrenal hyperplasia. Finally, 3. Ambiguous genitalia in a girl. Ambiguous genitalia in a girl. Sir, what is the investigation of choice? All are associated with increased precursors. What is that precursor? 17-hydroxyprogesterone. So the screening investigation of choice, the investigation of choice in suspected congenital adrenal hyperplasia is 17-hydroxyprogesterone. What is the treatment? In 21 alpha hydroxylase, you don't have aldosterone, so you give fludrocortisone. And you don't have cortisol, so you give hydrocortisone. Whereas in 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency, you have excess BP. So give only hydrocortisone, no fludrocortisone. Finally, what is the antenatal management? The mother is saying, sir, I have a child previously found to have ambiguous genitalia. I don't know whether it is a boy or girl. Right now I have conceived. How to prevent that, sir? I don't know whether this child will also be having that kind of 21 alpha hydroxylase deficiency. Save my child, sir. The mother is saying, what will you do? Start dexamethasone as soon as the mother is conceived. Start dexamethasone. Why? This dexamethasone to the mother will go to the fetus and it acts like a cortisol, so that it will switch off the ACTH. When it switch off the ACTH, that precursor getting converted into testosterone cannot happen. So start dexamethasone. Then at 10th week, you give chorionic villus sampling. If it is a boy, you need not worry, because he is going to have a good size genitalia. So stop dexa. If it is a girl, continue dexa till delivery. That's it. Congenital adrenal hyperplasia is over. Hyperplasia is over. Okay. Hyperplasia is over. Okay, baby. And let me repeat. When will you suspect? So what will happen? When will you? Finally, again one more point. The most common is 21 alpha hydroxylase deficiency. Alpha hydroxylase deficiency characterized by ambiguous genitalia, girls. Precocious puberty, boys. Presentation is shock, hyperkalemia, hyponatremia, and then metabolic acidosis. What is the investigation you do? 17-hydroxyprogesterone will be more than 1000 nanograms per liter. What is the treatment? Start hydrocortisone, start fludrocortisone. This is classic salt losing form. This is called classic salt losing. And finally, it is almost 11:16. The final MCQ is this. We'll try to have one more session, but for now, The final MCQ based on this is, sir, improve the following. I know all of you will be correct. A, PPT. B, hairstyle. C, backdrop. And finally, D, handwriting. So what is the MCQ for this? Choose the best answer. Choose the best answer. With this, I am signing off on behalf of PW. Let us meet. If possible, let us have one more session. So, what is the answer for this one? The answer is obvious. You will all be correct. Shall I sign off for today? All the above. Die. Okay. Right. Right. So, with this, we are finishing for the topic for today on pediatrics. Let us meet, if possible, in one more session. Good night. Have a nice. Okay. Have a nice day. Okay. Revise all. We'll meet soon. Bye bye. Thank you. I am signing off. I am signing off. So, team PW, shall I wind up? Stop streaming.